The joint infection panel or the multiplex PCR has a broad list of organisms, especially anaerobes, many of which are also found in intra-abdominal infections. So there's an overlap of the organisms that are covered. All the expected organisms in this collection, which we had expected, are covered in this panel. And multiplex PCR was done on the pus aspirate. And rightly enough, as you all can see, all of these organisms were detected in the patient. So Enterococcus faecium, strep species, E. coli, Klebsiella, and along with Candida. So here, as you can see, Candida albicans was not detected, it was just Candida species, along with resistance genes of CTXM, NDM, OXA48 like. So I just like to stress that why the multiplex PCR is important in this condition is she had received multiple antibiotics earlier. So we may not get any growth on culture, right? So the culture confirmed, fortunately for her, that all these organisms were found in the GI panel. It was confirmed on culture. So it was a carbapenem-resistant Klebsiella pneumonia, E. faecium, which was fortunately not vancomycin resistant, and ESBL E. coli, and Candida tropicalis. So Candida tropicalis was azole susceptible. So we switched from micafungin to an azole later after source control was done and the abscess was drained. So synergy test was done on Klebsiella and it was positive. So we continued with ceftazidime avibactam aztreonam. So if there was a drain in place, would you send a GI biofire or culture from the drain? Okay, so fluid from surgical drains is often not sterile, colonized with skin flora, nosocomial organisms, not representative of true intra-abdominal infection and leads to false positive cultures. However, drain fluid can be used up to 24 hours. After 24 hours, drain fluid testing should not guide therapy. So I'll just cover the PK/PD considerations of all the three antimicrobials that we've used quickly. So PK/PD considerations for ceftazidime avibactam. The PK/PD parameter for ceftazidime avibactam is the free time above MIC, which is expressed as percentage of dosing interval. So now, for example, if, like it says here, at least 60 to 70% of free time above MIC with high probability of target attainment. So that means that we want a level of ceftazidime avibactam above MIC for at least 6 hours of the 8 hours of dosing interval. So expected PK changes increase, I'll just wrap up. So here basically what I want to stress on is in ceftazidime avibactam, we have to use an extended infusion. In case of tigecycline, I just want to mention that it's very good for intra-abdominal infections and soft tissue infections. A high dose can be used for treatment of MDRO, VAP and CAP. But in case of bacteremia and UTI, it's not the drug of choice. In case of antifungals, suboptimal antifungal concentrations are known to occur in the intraperitoneal cavity. So penetration of echinocandins is only around 30% and therefore higher doses are preferred in IAC. And fluconazole, unpredictable concentrations in critically ill patients, only 50% penetration. So I'd like to end my talk with saying empiric therapy should be tailored to cover expected organisms based on patient illness, receipt of prior antibiotics and local hospital epidemiology. Source control should be attempted whenever possible and dosing of antimicrobials must be based on PK/PD considerations. Thank you.
Thank you, Dr. Maya. That was wonderful and illustrative explanation of what we really get in our daily ICU rounds. Thank you once again. Any questions from the audience? Okay. I'd like to thank Dr. Nitin. Okay. If there are any questions, we can take it in the later session. Uh, we like to thank Dr. Mundle sir and Dr. Joshi madam for chair, and we request chairpersons to proceed to felicitation area, please.
Check, check. 2 minutes. Good morning, all. Good morning, teachers, seniors, and friends. We have with us in our next session Dr. Srinivas Samavedam. Because of some personal reasons, he could not make it for the conference physically, but he is kind enough to be here with us online on Zoom link. Dr. Samavedam is at present president of National ISCCM in the current body, and the MOCs will introduce him. Over to you, Tushar.
So from here we move on to our next session, that is plenary session. And for plenary session, I'd like to invite expert panelist, Dr. Sunita Kumbhalkar. Dr. Sunita Kumbhalkar, madam, is head of the Department of Medicine, All India Institute of Medical Sciences, Nagpur. Welcome, ma'am. Dr. Mahesh Fulwani, sir. Dr. Mahesh Fulwani, sir, is senior interventional cardiologist of Nagpur city. And Dr. Dinesh Kabra, sir. Dr. Kabra, sir, is a senior neurologist with SIMS Nagpur. Welcome, sir. Mahesh, sir, please. We just introduced you. Welcome. Dr. Yogesh Kakas. Dr. Yogesh is a senior intensivist working at Sambhaji Nagar, and he is going to be the next torch bearer for Maha Criticon 2026. Welcome, Dr. Yogesh. And Dr. Venkatesh Dhaat, sir. He is chairman ISCCM Pune. Welcome, Dr. Yogesh. Yeah. Good morning, Dr. Samvedan. I hope
Good morning.
Yeah.
Can you hear me?
Yeah, you're very much audible as well as visible. So, how is your health?
I'm good.
Yeah.
Thank you.
Great to hear. Over to you, Dr. Samvedan.
Okay.
Dr. Deepak has already introduced you. I hope you were online at
Can you please permit me to share my screen?
Yeah.
Good morning, everybody, and greetings from the Indian Society of Critical Care Medicine. I'm honored and privileged to be speaking today at the Maha Criticon. This has been a landmark conference, always looked upon or looked forward to by a lot of students and young intensivists from across the country, not only from Maharashtra, for the extraordinary content and the array of speakers who actually deliver their lectures during Maha Criticon. Unfortunately, I am unable to attend this meeting personally, and my apologies to the organizing team for dropping out at the last minute, but it was unavoidable. I'll try to do my best as much as I can as in a virtual format. Can you see are my slides visible?
Yeah, now they are. Yeah, it's visible.
Are they moving?
Yes.
Are my slides moving?
Yes.
Okay. So good morning, everybody. In the next 20 minutes or so, I will try to take you through to this little bit of challenging problem for intensivists to manage sepsis, and that is myocardial depression in sepsis. If you look at it, myocardial depression in sepsis is not a single condition. It can have multiple triggers, it can have multiple perpetrators. Microcirculatory and mitochondrial dysfunction is probably the most currently accepted pathophysiological basis for myocardial depression that happens in sepsis. But before that, what we understood about this entity was the hypoxemia and the acidosis that are often present in patients who are critically ill, the autonomic dysregulation and the catecholamine resistance that happens in advanced vasodilatory shock, increased nitric oxide and other oxygen-free radicals, the presence of endotoxins and other bacterial components, as well as the myocardial depressing factors like tumor necrosis factor alpha, interleukins, and other mediators were responsible or thought to be responsible for the etiopathogenesis of myocardial depression in sepsis. Apart from that, the higher use of catecholamines in the management of patients with septic shock was thought to trigger an ischemia and also produce a scenario similar to a hibernating myocardium. But now MMDS seems to be the one integrating mechanism of putting all the things together and producing myocardial depression in sepsis. So how do you diagnose myocardial depression? There is a proposed diagnostic criteria for sepsis-induced cardiomyopathy. This is not the tachycardiomyopathy or the Takotsubo cardiomyopathy, which we all know that happens in sepsis. This is a little different. Sepsis-induced cardiomyopathy or myocardial depression is an acute and reversible process and usually should resolve within 10 days. If this process persists beyond 10 days, an alternative diagnosis has to be considered. This is not a focal apical syndrome that happens in Takotsubo, but rather it's a global biventricular dysfunction happening during both phases of the cardiac cycle with reduced contractility, and it is not a hyperkinetic circulation or a hyperdynamic state as we see in the Takotsubo cardiomyopathy. The left ventricle is also dilated, but there is no preponderance for a particular anatomical part of the ventricle as happens in Takotsubo cardiomyopathy. This kind of myocardial depression is characterized by a diminished response to fluids and catecholamines because the ventricles have become dilated and non-compliant to fluid boluses. Most importantly, before we make a diagnosis of sepsis-induced myocardial depression or cardiomyopathy, acute coronary syndrome has to be excluded with every certainty before you label this as a sepsis-induced cardiomyopathy. So these are some of the diagnostic criteria for septic cardiomyopathy or myocardial depression in sepsis. So how does the inflammatory cascade affect the cardiac function, or what is the cardiac impact of the inflammatory cascade? The trigger, that is sepsis, initiates a systemic response which results in a cytokine storm. While we understood about the cytokine storm during the COVID pandemic, this phenomenon does exist and has existed prior to the pandemic as well. This is characterized by a massive release of cytokines, which we have discussed, and also is associated with other depressant factors like reactive oxygen species. Therefore, the myocardial contractility is disrupted and the cardiac function is suppressed by nitric oxide dependent as well as nitric oxide independent pathways. And this inflammatory cascade represents a double-edged sword. That is, the immune system's attempt to fight the infection causes harm to its own ally, that is the heart, and it damages the heart's ability to pump effectively. So all your attempts at improving the stroke volume by fluids or other therapies will fail because the heart has simply lost the ability to pump its inflow forward. The mitochondrial and microcirculatory dysfunction, that is the MMDS which we discussed, is a microvascular failure where the impaired myocardial blood flow happens despite seemingly normal global perfusion pressure. So there is a discrepancy between the blood flow versus the pressures. So you can have a very good mean arterial pressure and still the patient can have myocardial depression. The mitochondrial dysfunction that happens because of this mismatch causes severe ATP deficits, starving the cardiac muscle cells, and therefore the contractility and therefore the inotropy of the heart reduces. The receptors are also downregulated, and the beta adrenoceptor suppression reduces the ability of the heart to respond to catecholamines. So in some situations, we tend to label this as advanced vasoplegic shock, but this could actually be septic myocardial depression. So this is the sequence of events that happens from infection where the pathogens happen. There is an immune response. This immune response triggers the first acts on the peripheral vascular beds where we get the leaky capillaries and warm shock, and then it progresses to the calcium handling problems and the MMDS which we discussed, and resulting in a decreased cardiac output and then pulmonary edema, which is the end stage of septic myocardial depression. So this is the sequence of events that happens during a septic myocardial depression. In sepsis-induced cardiomyopathy or septic myocardial depression, the metabolism is also deranged. So these patients will have a decreased fatty acid oxidation, decreased fatty acid uptake by the cardiac muscles, which deprives the myocardium further of the energy, and there is decreased expression of enzymes which are related to fatty acid metabolism, and therefore lipid accumulation happens in the cardiomyocytes and their contractility depresses further. Carbohydrates are also impacted by a decreased glucose oxidation and insulin resistance and a decreased cardiac glucose uptake. There is also decreased ketone body uptake in the cardiac muscles and an increased lactate uptake. So the muscles, the myocardial fibrils are operating in an anaerobic energy-starved environment. So their force of ventricular contraction therefore is reduced. The pathophysiology, as we have said, depends upon mitochondrial dysfunction, oxidative stress, abnormal calcium transport, coronary microvascular maldistribution, downregulation of the beta adrenoceptors, and myocardial depression. So our therapy for sepsis-induced myocardial dysfunction or cardiac dysfunction should focus on addressing all these aspects. And that is probably the rationale where liberal oxygen therapy may sometimes be detrimental. Some role for levosimendan in this context because of the calcium abnormalities, and probably a little bit of role for methylene blue in this context because of the downregulation of the beta adrenoceptors and the maldistribution of the coronary microvasculature. We don't have published randomized control trials on this, but this is the pathophysiological rationale where some of these molecules may be useful in patients with sepsis-induced cardiomyopathy or myocardial depression. So I'll just put it in a more pictographic way. So it is the nitric oxide, the cardiac factors, the calcium influx, autonomic dysfunction, apoptosis, and all the changes will actually result in the septic cardiomyopathy. What are the commonly associated pathogens? Does every organism we encounter in sepsis produce it? There are certain organisms which are more likely to cause cardiomyopathy and myocardial depression than others. Our friends, the E. coli, Staph aureus, especially MRSA, Klebsiella, and Pseudomonas are all the top of the list for bacteria which cause sepsis-induced cardiomyopathy. Among the fungi, Candida is notorious for producing cardiomyopathy. Herpes simplex, Coxsackie, and parvovirus diseases can produce sepsis-induced cardiomyopathy, but the mechanisms by which they produce are a little different. While the bacteria act through the mechanisms we have discussed so far, the viruses act through the AC2 receptors and the toll-like receptors signaling pathways. And there's a direct damage to the endothelium which impairs the cardiac microcirculation. End result is the same. There is a mitochondrial dysfunction and mismatch in patients with any infection-related myocardial dysfunction, and these are the common organisms which can produce. Having said that, no data exists regarding the role of Mycobacterium tuberculosis, but we have seen patients with tubercular myocarditis and cardiomyopathy with florid pulmonary tuberculosis. So how does it manifest? Are there any clinical sign conons of septic myocardial depression? Unfortunately, no. But the cardiac hallmarks of sepsis-induced cardiomyopathy are biventricular dilatation with a markedly reduced ejection fraction. Both the left and right ventricles are affected simultaneously, and there is combined systolic and diastolic dysfunction. It is reversible in those who survive this storm of 7 to 10 days. The heart's remarkable ability to recover distinguishes septic cardiomyopathy from other forms of heart failure, which offers some hope for critically ill patients, and also would probably caution us not to be over-aggressive in looking at interventions for these patients in the very early phase of septic myocardial depression. This is the era of phenotypes, and sure enough, there are several phenotypes of sepsis-induced myocardial dysfunction. So in septic shock, there can be new onset cardiac dysfunction, or there could be a worsening of underlying cardiac dysfunction. Also, the vasoplegic shock or catecholamine resistance should also be looked at from a possible myocardial component. So the pattern 1 is a vasoplegic shock, or the phenotype 1 is a vasoplegic shock. The pattern 2 is a cardiogenic shock, where the pulse pressure is narrow and the wedge pressure is high and your hypotensive predictive index is very high. In pattern 4, there is a superimposed, there is a normal pulse pressure, your resistance is also normal, your systemic vascular resistance is normal, but your wedge pressures are high. And there is a full-blown cardiogenic shock where all parameters which are defined with a low ejection fraction, low cardiac index, and a narrow pulse pressure and a high wedge pressure, all these are in the phenotype 5 of septic myocardial depression. At this point of time, the gold standard remains echocardiography because it is easily available, it can be done by bedside, it can be replicated, and it is safe for the patient. The echocardiography is essentially used to detect systolic dysfunction as well as diastolic impairment. The echocardiography usually identifies a reduced ventricular ejection, left ventricular ejection fraction of less than 30%, which is the hallmark of severe cardiac depression. On the diastolic side, it detects filling abnormalities that often precede systolic dysfunction and signal early cardiac involvement. So, your early diastolic dysfunction, if it is progressing to grade 2 and grade 3, it is a harbinger or a herald sign for systolic dysfunction in the future. Right ventricular assessment is very important in these patients, as it is for most critically ill patients. RV dysfunction and dilatation will serve as critical early markers of disease severity and prognosis. But the key is serial echocardiography is essential. One stat reading or one stat study is not going to be enough. A single normal study at the beginning of the hemodynamic instability and the vasopressor resistance does not rule out evolving myocardial depression in sepsis. So it is characterized by a decreased cardiac output, LV dysfunction with an ejection fraction of less than 30% and a global longitudinal strain of less than 20%. There is also evidence of LV diastolic dysfunction with the E by E prime ratio of more than 13 centimeters per second. Then there is evidence of RV dysfunction, most easily appreciable in the ICU by a TAPC of less than 16 millimeters, which is something which will tell you that there is a biventricular dysfunction. So if you look at the values suggestive of septic cardiomyopathy, for LV systolic side, you have the LVEF, the MAPC, and the GLS. If the MAPC is less than 11.65, it is easy to obtain, but it is dependent on the angle you are using, and it varies due to cardiac size, and it can sometimes fail to detect regional myocardial abnormalities. The LV diastolic dysfunction, as I said, is measured by the E by E prime. It is also easy to obtain, but it may be affected by the age and regional valve motion abnormalities. And we know about TAPC, we routinely do it in the ICU, but it may be affected by LV dysfunction and sometimes upstream of, problems like ARDS, for example, that may impact your measurement of your tricuspid annular plane systolic excursion. How does it differ from stress cardiomyopathy? Stress cardiomyopathy is more diagnosed in the ICU, sometimes overdiagnosed, I perceive. The primary trigger in sepsis-induced myocardial depression is a systemic inflammatory response. But infection is not the only trigger which can cause stress cardiomyopathy. Trauma, pancreatitis, burns, all can cause the stress cardiomyopathy. The underlying mechanism of sepsis-induced cardiomyopathy is very complex, involves cytokines as well as effects of nitric oxide and mitochondrial dysfunction. Whereas the stress cardiomyopathy is essentially a catecholamine response, an acute and excessive response to catecholamines which directly damages and stunts the cardiac muscle. Echocardiographically, in sepsis-induced myocardial dysfunction, you find a global non-regional reduction in the contraction of the ventricles, often with dilatation and biventricular distribution. Whereas stress cardiomyopathy is characterized by a specific regional wall motion abnormality with apical ballooning, and the RV is not usually involved in stress cardiomyopathy. So what are the biomarkers and how do you predict the onset of stress-induced sepsis-induced cardiomyopathy? The key biomarkers is the NT-proBNP. Elevated NT-proBNP levels strongly correlate with the severity of myocardial depression and predict adverse outcomes. But good number of these patients are also oliguric and are on renal replacement therapy. So the cutoff for NT-proBNP above 3000 has to be taken into account for suspecting patients who are progressing to sepsis-induced myocardial depression. Certain patient profiles are known to be high risk or have been identified to be high risk for the genesis of sepsis-induced cardiomyopathy. Younger patients paradoxically are at a higher risk. Those with pre-existing diabetes and heart failure are definitely at risk. And if your blood culture is positive for one of the 5 bacteria which we'll discuss in the earlier part of the presentation, the risk increases by 2 to 2.5 times. The risk of mortality increases dramatically in those patients who have a persistently low EF and do not show ventricular recovery by day 10. However, if the recovery does not happen, we need to look at an alternative diagnosis if it is treatable. So sepsis-induced cardiac dysfunction needs a multi-level and multifaceted monitoring like hemodynamic monitoring, sonographic monitoring, biochemical monitoring, and clinical assessment. In hemodynamic monitoring, we discussed about the blood pressure, the central venous pressure, but most importantly, we need to look at some form of cardiac output. Whether you look at the global end diastolic volume index or the cardiac index, they are indices which will guide you regarding the progress of this patient. Interventions may not make a difference, but we don't have strong evidence yet. As we discussed, echocardiography remains the cornerstone of monitoring these patients and serial echoes are required. Troponins and BNPs are usually done for these patients as well as lactate levels. Clinical assessment is sometimes erroneous in these patients because of the impact of positive pressure ventilation, but looking at the fluid balance is a very important aspect because these ventricles are no longer volume respondent. So if your patients are hugely overloaded, then you have to look at a de-resuscitation strategies for these patients as well. How do you manage them? The first step is still fluid resuscitation. Early aggressive IV fluid administration to restore the intravascular volume and give that kick to the right side of the heart to generate a forward flow with goal-directed therapy and dynamic assessment. But use ultrasound judiciously and meticulously to avoid fluid overload. The second step would be to initiate vasopressor support with norepinephrine as a first drug, targeting a mean arterial pressure of more than 65. But more than the mean arterial pressure, it is the perfusion pressure that makes a difference. So look at the diastolic blood pressure and try to see to keep the perfusion pressure above 55 millimeters of mercury. Third stage would be anti-inflammatory therapy, and this is where probably low-dose hydrocortisone comes into the picture. It may not be applicable to all patients with septic shock, but definitely those with the early myocardial depression seem to have some benefit with the initiation of hydrocortisone, contrary to popular belief that hydrocortisone retards the recovering myocardium. Lastly, we should consider inotropic support. At this point of time, dobutamine is the only inotrope which has been used in patients with sepsis-induced myocardial depression. It is reserved for patients with persistent hypoperfusion, but there is a risk of arrhythmias and increased oxygen demand. Levosimendan has been used, but currently we do not have grade 1 evidence to say it is better than dobutamine for the management of sepsis-induced cardiomyopathy. No discussion about this condition can be complete without bringing in ECMO into the discussion. Both forms of ECMO are indicated in this form of disease, veno-venous as well as veno-arterial. So you look at the echocardiogram and you make a diagnosis of septic cardiomyopathy with a lower cardiac index. try with dobutamine or even milrinone and levosimendan. If there is a persistent shock and dysoxia and a very high SCVO2, then you do speckle tracking echocardiography. If the speckle tracking echocardiography shows predominantly RV dysfunction, we can manage with veno-venous ECMO with the drain in the right jugular and the return in the right femoral. But if the cardiac index is you preserve, you try to use vasopressors. But if there is an LV dysfunction with an LVEF of less than 25%, you have to consider central vena arterial ECMO. Ventricular assist devices have been tried in anecdotal cases, but they are not yet part of the mainstream algorithms for the management of sepsis-induced cardiomyopathy. IABP has not been shown to improve outcomes in patients with sepsis-induced cardiomyopathy. So this is the summary. You look at the severity of the clinical presentation and then you increase your intensity of your interventions. Treat the cause will be applicable to all conditions which start with sepsis. So fluid expansion, vasopressors, inotropes, and mechanical support will be the way you should go in patients depending on whether there is septic shock with septic cardiomyopathy or decreased RV function or decreased LV systolic function. Based on this, we can identify. Certain therapies are emerging, mainly mitochondrial targets, receptor modulation, immunomodulation, and precision medicine. Mitochondrial targets, novel therapies aimed at preserving the mitochondrial function and ATP production. Receptor modulation, which strategies to restore the beta adrenoceptor sensitivity. Methylene blue is one option. Immunomodulation like rituximab and infliximab have been tried in these patients with variable results, but importantly we need to pick and choose our patients for personalized therapy. So these are the various novel therapies, but not all of them are in animal stages like melatonin, gene therapy and hyperinsulin therapy and cystosoma produced cystatin. Maybe 5 years from now, some of them may be evaluated in major randomized control trials. So I will conclude by summarizing that an infectious trigger produces sepsis-induced cardiomyopathy mediated by the immune response where cytokines, oxygen radicals and complement play a part. There is a myocardial depression with dysfunction and oxidative stress mediated by the DAMPs. Clinical diagnosis is the key. Serial echocardiography is the clue. And judicious use of fluids, early initiation of vasopressors, and timely initiation of inotropes will salvage most of these patients. If this fail, you can go for extracorporeal support. I would take this opportunity of welcoming you all for the 32nd annual conference of the Indian Society of Critical Care Medicine at Chennai. Please do join us for more such insightful sessions like what you are seeing in Maha Criticon. Thank you very much. Have a good day. My apologies again for not being there in person.
Thank you, Srinivas Samavedam sir. We are very thankful that you are available online with us. Any questions from audience? Okay, then we are going to press.
Yeah, madam, please.
Thank you, sir. It was very excellent talk. I just want to know, is there a role of in the echocardiography of the speckle tracking to identify early cases as compared to the non-speckle any parameters of the echo?
So, if we are still unable to come to a conclusion by routine cardiography and the patient is crossing 4th day or 5th day of this condition, then it is probably advisable to do speckle tracking. But it's a technically challenging thing, but that's the only thing that will give us very clear clue that the myocardial depression is improving or not improving.
And what is the dose of methylene blue as we can view in this case?
So methylene blue is something which is used in different dosing patterns, but what has been used in septic myocardial depression is 1 milligram per kg per day, but you have to reevaluate every day, and after you cross 3 milligram per kg per day, you have to revise whether it is actually working or not. In an Indian context, G6PD deficiency has to be sought after, and non-oliguric patients there is no issue. But for oliguric patients, you can use methylene blue only if you have put them on CRRT. Intermittent hemodialysis patterns can cause extensive hemolysis if G6PD deficiency is superadded.
Thank you, sir.
Thank you very much, Srinivas Samavedam sir. With that, I invite our next esteemed speaker, Dr. Kapil Zirpe sir, to please deliver his talk. Sir will be speaking on curing coma in Indian perspectives. Dr. Kapil Zirpe sir is head of Neuro-Intensive Care Unit at Grand Medical Foundation, Ruby Hall, Pune. He is past president of ISCCM, past president of RSSC. He also has been vice chancellor of Neurocritical Care Medicine. He has 16 books, 44 chapters, and more than 160 publications and projects. Thank you. Over to you, sir.
Good afternoon, and I take this opportunity to thank you, Maha Criticon, entire team, enthusiastic team. And yesterday we finished the workshops with that enthusiasm. And I'm changing your mood from sepsis infection to the traumatic brain injury. And I am just going to present in next 15 minutes the thought-provoking area of the critical care medicine or traumatic brain injury in front of you. That is a curing coma campaign. Now, this is a case scenario. This was a 21-year-old male. He faced with the road traffic accident, severe traumatic brain injury. GCS was 4. He underwent the decompressive craniotomy. He was almost there more than 2 weeks in outside the hospital, and with the political support, then they called us and they said that they want to shift to the Ruby Hall. So I asked the first question, what is the current condition? They say pupils are 3 mm sluggish reacting light. When somebody says sluggish reacting light, doubtful. They are most of the time they are non-reacting, and they want to just transfer their headache to the tertiary care center. I said, after 2 weeks, why you are transporting? They said, no, the relatives are insisting. I said, first 2 weeks, what relatives were doing? No, we are doing the emergency procedure. I asked, first 48 hours is the emergency life-saving procedure. For 2 weeks, what you are doing? They say, sir, be frank with you, that patient has no prognosis, is almost brainstem death, and relatives are not accepting. We want to shift to the your center, and you just please relieve us from the stress of the political. So we decided to take this patient. Remember this history at the end, okay? So we received this patient and we started our regular protocol-based management, and I will come to that what happened to this patient. So whenever any traumatic brain injury patient comes to you, first thing the relative will ask you, what is the prognosis? Is my patient is going to survive? Is how many days he will be ICU? What you are going to do the intervention? So there has to be the prognostic models. Every disease in critical care medicine has a prognostic model. You can't say that I don't know. You can't say that it is unpredictable. You can't see the patients and the relatives are paying from their pocket. Only 20% has a medical claim. You can't give them the vague answer. He may come out, he may not come out, he will open eyes, but he will be bedridden, he will be off ventilator, but he will never come out of the bed. This is what we are giving the prognostic to our patients and expecting that they will pay you. After 2 weeks, 3 weeks, lakhs of the payment, still we are confused. No need of confuse. We have to give them the clear prognosis. We have to tell them that on 3rd week onwards, there are chance of the recovery. After 6 months, he may walk. After 1 year, he will be normal, near normal, and he will go back to work. Why can't we tell? It is possible. There are various prognostic modules are available in a traumatic brain injury. You go through, they are online, impact, crash, and there are so many things are there. You can give them the prognostication of the patient. Now, you will be surprised to know, this was a 2024 Neurotrauma Surgical Journal was published a patient. We said majority of the patients in India are discharged with the Daman Lama, discharge against medical advice or left against medical advice, either financial reason or majority time we don't give them the clear picture. We say that he may come out, but he will not come out. So they say, okay, we'll go to the nearby hospital or the government hospital because we are not confident. And somebody followed those patients, and you will be surprised to know this evidence-based paper says 40% of the patient has a chance of survival when they got Lama. Look at, we don't know what happened to them. When patient leaves your ICU or hospital, we never know what happens to that patient, whether he survived or expired. But this paper followed 40% of the Lama or Dama patients have a chance of survival. Who we are to send them home? This was a very good quote. This is Michael Schumacher. Everybody knows he is known for his speed. He met with the accident. He had a severe traumatic brain injury. He was under the artificial coma. His rival, his competitor Maha. When he came to see him, he written an excellent quote. He said, all the time on the court, we were beating the time. He said, now don't beat the clock. Take your own time, but come out. See, excellent. See, this is the way we should look at the traumatic brain injury. Who we are to say that after 2 weeks this patient is not going to survive? Who we are to say that after 1 month this patient has a vegetative life? They may come out. We are not aware how to diagnose and how to, and that is the curing coma campaign. So we have to come out of that negative mentality. Do not resuscitate. Do not do any aggressive treatment. Do not mobilize this patient. This patient has a bad prognosis. There is a culture, there is a pervasive theme that the GCS of less than 4 after the 2 weeks has the chance of the 5% survival and they will never come out. No, nothing like that. There are so many examples, patient comes back in a walking stage. So what we need to do, we need to promote the curing coma complex. I always I always curse the movies and this thing because they have damaged our reputation, they have damaged the organ donation, they have damaged the coma concept. If they want to change the heroine, they send the patient, their artist into the coma. That is not the way you can promote the coma. Coma is reversible. Coma is reversible. Please don't use coma terminology in your day-to-day life. Prevent. Just get away from using the coma terminology in your ICUs. So ask these questions. Is he going to die? 21-year-old, 3 weeks of the survival, GCS of 4. That hospital sent to us for the organ donation. Already it is defamed. Organ donation is already defamed. And I have to be very careful with this such patient. But the only young criteria with the rest of the prognostic model, we decided to go ahead. I asked the very simple question, what relative is going to ask me? If suppose I see the patient and I face the relatives, what relatives are going to ask me? Is it going to survive? How long? What is the expenditure? Is he will be near normal life? Can he recognize me and my family? Can he do his day-to-day work? Very simple questions. And the answers are very simple, but we never give. Go back to your counseling. We say we are always the threat of the medico-legal. There must be session in Maha Criticon on the legal. They say don't document, don't tell anyone, give them the picture which is blood, don't tell them the exactly. No, legal things are not coming into your treatment. You have to face them as it is like, why can't I save this patient? Why can't he wake up? And for that there is a way to go ahead. That's what 2019, the NCS Neurocritical Care Society of USA launched the Curing Coma Complex. See, look at the Western world is 10 steps ahead of that. It should be done by India. We never do that. We always cry that we do not have resources, we do not have resources, but we have a luxury life. So, Curing Coma Complex is run by the Western countries. All these evidence-based papers are done by the Western countries. We only discuss on such platform and try to get the awareness. So what they did, first they said get rid of the coma terminology. They said define the state of the unconsciousness. Define the endotypes of the unconsciousness. Define the biomarkers which can help you to do the prognostic. Do the point of care research and come with your own evidence. And with that, the first thing they define the definition of the coma. They are against coma. Nobody uses nowadays the word coma. They say disorders of unconsciousness. These are the disorders of unconsciousness, unconscious, semi-conscious. These are the disorders of unconsciousness. Go back to the etiology. Whether it is a structural damage, traumatic brain injury, stroke, IC bleed, no structural damages, metabolic coma, reversible, this thing like that, or stroke, or the unconsciousness mimic. Barbiturate coma. Barbiturate coma is something like it is mimicking the brainstem death. So they say define now the new terminology used in neurocritical care is the disorders of unconsciousness. If somebody say what is your status, you can say unconscious because of the traumatic brain injury. So it is an unconscious category, disorder of the unconsciousness with the structural damage. With no structural damage, locked-in syndrome. So like that, you first learn to use the terminologies in the right way. Positive mindset. Biomarkers. You are so much enlightened with the sepsis biomarkers. Why not traumatic brain injury biomarkers? There are so many biomarkers are available. like there is a S100B, there is a GFAP. So these are biomarkers can help you to even delay the MRI, to know the frequency of the CT scan, whether it is necessary, what CT scan is going to give me the idea. You can do these biomarkers. That gives you the idea whether this patient has a prognosis or this patient has a We do not do the imaging. One of the biomarker is the imaging. Functional MRI, how many times you do the functional MRI? Functional MRI exactly gives you the idea whether your patient has how much is a reversible brain and how much is irreversible brain. So after 2 weeks of the presentation, if you do the functional MRI and it gives a lot of reversibility, why can't you? I can tell my patient, this patient is going to survive, this patient may come out, he may come out with the functional outcome. So these are the various models. So coma is out, disorders of the unconsciousness, whether he is unconscious, whether he is unresponsive, minimal responsive, response to pain. According to that, do the CT, MRI, functional MRI, EEG, quantitative EEG, TCD, like that you add on as per your indication to just come giving you the confidence that we should try in our patient. At the end of the day, it is very easy to say in the Daman Lama, these are all youngsters, they have entire life in front of them. So please don't send any patients without you give them the proper evidence-based prognostication. Yeah, financial reason, that is a different reason. I'm not here to explain that. So key point is that investigate. Do investigation, do imaging, repeat imaging, do functional imaging, do EEG, do quantitative EEG. These are available. These are available in India. You can't say that we are a resource-limited country. These are very regularly available in India. Or they must be available in CT. Do that. That is going to help you for the prognostication of this patient, and that is going to give you the result. Trials. How many Indian trials happen? Nothing. We have done the survey. I am going to present, but we did the survey. Nowadays, there is a fashion of doing the survey. Every alternate day, there is a survey on the WhatsApp. This is not a research. This is not a research. This is just opinion pool. And what is the value of the opinion pool in the election? The same value as the opinion pool on that. Because in a one unit, 10 guys fill up the same survey. So that particular unit mindset is not the entire India representative. But average participation of the survey is 100 plus. We have intensivists 25,000 plus. How can be that sample is, and that is also survey. Who feels what, in what condition they feel, who guides them, nobody knows. We need to do the trial. All trials, evidence-based trials are from the Western countries. This is also when we did the survey. 137 participants. But that gives us just idea that what is the commonest cause of the unconsciousness in India. More than 50% is the traumatic brain injury, then the stroke, then IC bleed, and then rest of the conditions. So we come to know that the traumatic brain injury is a major challenge in India. We come to know that there is hardly any diagnostic facilities. We face a huge facility issue with the MRI. CT scans are available. Functional MRI is no concept in India. I'm not aware which neurotrauma units do the regular functional MRIs after the few weeks. Which neurosurgeon advice, I am not aware. So we conclusion that typical crying baby, we face the shortage of the healthcare workers, we face the facilities, we face the, how long? After the 30 years of the Indian Society of Critical Care Medicine, after the 25,000 of the intensives are available, how long we are going to? One of my friends said very nice thing. He said India is the two, one in one. One is the rich India, one is the poor India. Like a few institutions have everything. They have functional MRI, they have biomarkers, they have ECMO, advanced ventilator, transplant, everything. And another institute don't even, they have hardly as a CT scan. So we represent the two India. One is the rich India and one is the poor India. So this survey is probably the poor India. Okay? Because in my hospital, Ruby Hall, there are 6 neurosurgeons, 6 neurophysicians, 2 MRI, 2 CT scan, 1 functional MRI, there is a transplant facility, there is everything is there. How can be a resource limited situation? I am the resource rich situation. I can't cry that I can't do the prognostication of the patient. So, last sentence, look at the last sentence. One of the easiest way of the disposition of the all unconscious patient is home. We have so hard to convince the relative to take him home. We say, what we are doing? We are giving RT feed, you can give. We are changing position, you can change. We can take care of the pressure sore, you can do. We are giving the oral antibiotic, you can give. You can call us online, and we have utilized all our intelligence to convince them to get the patient out of the hospital to the home. There is no intermediate facility in India. Ideally, there should be the intermediate facility in everywhere. These patients should go to the intermediate facility where the tracheostomy care, bedsore care, mobilization, physiotherapy, nutrition. Nutrition is hardly anything in on the card. So we send in the home, and we are always happy that we send the patient live on the home. Whether you send the patient live or you made that entire family paralyzed. Do you know how many rooms in his family? There is a one room, there is a one bed, and that patient is continuously lying on that. What you have seen in that 3 Idiot movie, we laughed a lot. You have seen that, na? She was simultaneously doing the scratching and then doing the. So that is what the true situation of India. We need to come out of that. We need to suggest to the government. We need to suggest to the hospital, get the intermediate this thing. This should not be the issue in our country. So we come up with the suggestion in a cure and coma campaign on an India basis that there is a huge knowledge gap. There is no resource limitation. There is a huge knowledge gap amongst the healthcare worker. We should work on the prevention rather than this thing. Like we should work on the use of the helmet. We should work on the condition of the road. We should work on the traffic rules. We should promote. Why can't we play a vital role in promoting this to reduce that more than 50% burden of the traumatic brain injury and then treat them? These are the all other references. These are the solutions. This is what we do regular basis. We do the webinars, we do the communication, we do the healthcare, and we try to promote the unconsciousness. We try to say that you just go through the each and everything and diagnose the level of unconsciousness. Don't send them home. Don't send them to the other hospital. Treat them. Use your intelligence to help them rather than to get away from them. This is a very nice slide. We need to change the culture. We need to change the culture. Cultural change has to be there. Our mindset change has to be there. Coma is not brain death. Majority time the coma is misunderstood by the brain dead. Brain dead is a completely different entity. Coma is reversible. So don't say coma. If you say coma, now entire family will be negative because in society it is a negative stigma. Say he is unconscious. They will be say, yeah, something is possible. If you say he is in a coma, oh, then he will not come out. So that negativity should come out. Change the culture. We have to change the culture in healthcare. We have to change our mindset. Then we can change the mindset of society. Prognostic humility. There is a humility. About the coma, there is so much negativity. Even the doctors doing the rounds, we do so much negative comment, loose comment about the coma. Arey, he is in coma and there is no chance of survival. You know that I went to one of the hospital in south. There was a board written on the back side, I am listening. You know that? It's a very good board. What is mean by that? Unconscious patients are not dumb and deaf. They are listening. When you are commenting, अरे इसके पास पैसा नहीं है, अरे ह्याच्याकडे पैसाच नाही आहे, बहुतेक आपल्याला घरी पाठवून द्यावं लागेल, वाचण्याची तर काही शक्यता नाही आहे, ते तर काही बोलतच नाही आहेत. So this negativity, this humility should be come out. Please don't humiliate the unconscious patient. So what we need to do, we need to aggressively approach this prevention and the treatment part. We need to implement the technology wherever it is possible, use the biomarkers, use the functional MRI, use the more and more prognostic model. Do the maximum clinical examination. This guy, which I have shown the case, which came for the brain dead organ donation. So day 3, my nurse came and said that he is moving the one finger. That was a positive finding. GCS, local findings are the more important than that. So, develop the infrastructure, develop the, do the more and more research, and develop the caring facility. And that's what the coma, that's what the unconsciousness. Change the mindset. You just don't send them home. The first thing I would like to request, don't send any unconscious patients home without the proper prognostic evaluation. And this was a patient I explained who was sent to us for the organ donation. Look at, he's fully conscious, he's doing the physiotherapy, he's standing. This was 6 months back. Last month he came walking, he was a wrestler, and he asked me, can I join the wrestling back? This is what the coma. Thank you very much.
Thank you, sir, for your eye-opener talk on changing perspective in comatose patient. Any questions from audience?
Yeah, and I finish in time.
That was a passionate plea,
yes.
Dr. Kapil.
Yeah.
We are thankful for that.
You have really hit the right button that we have to be aggressive in management of comatose patients, especially patients with post-traumatic impaired consciousness, because they do better than those who have non-traumatic like hypoxic ischemic injury. They do better than them.
Yes.
And
Agree.
one of the key in management of any neurological patient is that you have to have patience. You can't see results in 1 day, 2 days, 3 days. So there is the art in treating these patients. Of course, we do the scientific part very well. So I do agree with you. We have to be aggressive and we have to be patient as well. Thank you.
Yeah, don't beat the clock. That's what that non-medical person said. And we are behind the clock. That's unfortunate. Okay? Chairperson? Thank you.
Yeah.
Thank you.
Thank you. Thank you, Dr. Jirpe. For next talk, I'd like to call upon Dr. Sachin Gupta. Dr. Sachin Gupta will be speaking on focus on an extended stethoscope. Dr. Sachin Gupta is Director Critical Care, Narayan Super Speciality Hospital, Gurgaon. He is General Secretary, SCCM 2025-26. He is North Zone Representative, National Executive. He is Chairperson, SCCM Gurgaon Branch in 2023-24. He is Coordinator of Research Committee, and with many publications, he has also authored more than 100 publications and presently National Principal Investigator of Dissect, Solute, Resuscitate Trial. Welcome, Dr. Sachin. Over to you.
Thank you, and I would like to thank the Maha Criticon team for having me here. I am a proxy batsman for Dr. Deepak Govil. He is not here, so this is my talk is later on, so I am proxy on his. So what I would be speaking on is, can lung be used as an extended stethoscope, or is it replacing the conventional stethoscope in the intensive care unit? And yesterday during the POCUS workshop also we highlighted this point. So we all know that lung is a major hindrance for the use of ultrasound at the thoracic level. Now with this punchline, what's the point in this talk? We are talking about lung ultrasound and we say lung is the major hindrance. So see, air is a major hindrance for ultrasound. Where there is air, you cannot penetrate that region beyond that. Now lung is full of air. So what we interpret when we do a lung ultrasound is artifacts. It generates artifacts, and that is what the interpretation, and this is what pathology would come about. So I will go through this. So in last 2 decades, the transthoracic ultrasound has proven to be one of the most revolutionary diagnostic tool, and it is the most important armamentarium that we have in our daily critical care practice nowadays. We integrate it with our clinical signs and symptoms, and what COVID showed us the utility, the actual utility of lung ultrasound when we were not able to use this conventional stethoscope because of the entire, the suit that we were wearing, the PPEs that we were wearing, and that is where the actual utility of lung ultrasound came into the picture, and the research journals are flooded. If you look at 2020 to 23, each major research journal had almost 37% articles only belonging to ultrasound. So talk about, when you talk about medical science and you say 1/3 is by only one single technology, it tells you what is the impact of that technology in the present medical science. So yes, there is a shift in paradigm. We say lung ultrasound is more like a diagnostic. Yes, nowadays it is also as a monitoring tool. You monitor your patients based on the findings on a daily basis. What is the advantage? You compare it with your conventional chest X-ray that you do day in and day out for almost every single patient, whether it is required or not required. It's a dictum. You write chest X-ray blanketly. Most of the physicians do that. So we need to understand the specificity and sensitivity comparativeness. For all modalities of respiratory etiology in ICU, lung ultrasound has a sensitivity and specificity from 92 to 100%. So that's a very, very high sensitivity and specificity. And if you really want to compare it with chest X-ray, it never falls even nearer to this kind of sensitivity and specificity. So we need to re-understand, we need to actually rethink, do we actually require chest X-ray for every single patient? Or can we bypass that philosophy and only give it, a limited exposure in the intensive care unit? You compare it with the auscultation, again, very poor sensitivity and specificity of auscultation. Same is for radiology, and this is for pleural effusion, consolidation, and alveolar interstitial syndrome, or what we call as similar to a left ventricular failure. So what can ultrasound tell you? Ultrasound can actually tell you almost every lung pathology that you see in your intensive care unit, which is obviously the normal lung, plus the abnormal findings, so consolidation, pulmonary edema, pleural effusion, atelectasis, pneumothorax, pulmonary embolism. You can also actually undergo certain procedures, thoracocentesis, and so on and so forth, safely with the help of ultrasound. So this is a surface technology, and we only assess the surface and then we look at the artifacts. We know that all ultrasound machines have these three probes, but what we utilize mainly are two probes, the curvilinear and the linear probe, and this is how you place it on the patient in two views, the longitudinal view and the transverse view, to assess quickly and then to assess deeply. So once you are assessing it quickly and at one particular rib point you understand that there is an abnormal finding, that is the area that you want to evaluate it completely. So we divide the patient's chest theoretically into 6 different zones. So each hemithorax has 6 different zones. At the mid-sternal level, anterior axillary, posterior axillary line, 3 vertical lines, and then at the level of the nipple we divide this. So you have 6 zones. Most of the intensive care patients will have findings in zone 4, 5 and 6. So please do not forget to turn your patient at least once to have what is there at zone 5 and 6. That's the posterior part. So you will have findings when your patients are bed bound, fluid overloaded, and so on and so forth. So always evaluate these patients. And as I said, it's a surface technology, so air would rise up, the fluid would go down, it follows the laws of gravity. So this is the first view that we generate whenever we do a lung ultrasound, and when we have to talk about this, sorry, I couldn't find a pointer here. So what you see at the topmost part, which is non-mobile, right? So this part is the skin and the subcutaneous tissue, and what you see here is the pleura sliding. So with this, we call this as a lung sliding, which says this part of the lung is participating in ventilation. That's the basic interpretation of the clip. So the first part is the real image, because that's the skin and the subcutaneous tissue, and these are all artifacts. So lung generates artifacts, you interpret those artifacts, right? So the second important thing that you see is, and what we call as A lines, if you can appreciate, these are the horizontal lines which are parallel to the pleural line. A line stands for air lines, which tells us that this lung is aerated, this lung is participating in ventilation. And when I say lung sliding with A lines, this means this is a normal healthy lung. There is an M mode, a motion mode, you put that M mode and you get a picture like this, and we call this as a seashore appearance. The calmer part is of the sea and this granular part is of the sand. So when you see a sea coast from a distance, this is how it appears, and this is known as a seashore sign. Again, a representative that this lung is participating in ventilation. So this is very important when somebody who is hypoxemic comes to the ICU and you have this finding, you know what is the lung pathology. Is lung the cause of shock for this or respiratory distress, or there is something else that you are looking at, right? So the important interpretation is, if there are A lines with lung sliding and the patient is breathless, so there could be a non-pulmonary cause like pulmonary embolism, or the patient can have severe exacerbation of COPD or asthma. But if the lung is not sliding and there are A lines, This is very, very characteristic of pneumothorax. So again, the sensitivity and specificity of diagnosing pneumothorax with ultrasound is 100%. There is not even 99, it is 100%. So if you have certain specific findings, it is 100% that this patient has pneumothorax. Then the next lines are B lines, and B lines always are pathological in nature. So they stands for decreased aeration. So if you have B lines, it means there is increase in the water content of the lung. And this is more so, you know, if you have it bilaterally with a poor heart function, you say this is pulmonary edema. If this is unilaterally, patient is in distress, this could be consolidation, this could be pulmonary contusion if somebody is coming from a trauma scenario. So the number of B lines, if they keep increasing, this tells us more and more lung is getting wet, which means my patient will actually worsen on hypoxemia. On a reverse manner, if the lungs are going from C to B to A, this means whatever you are doing for your patient is helping your patient. The number of B lines are decreasing. So this is what we call as a monitoring part when it comes to lung ultrasound. The third point is what we call as E lines, is emphysema lines. So here, sorry. Yeah. So what we see is E lines, and when we say E lines, they represent emphysema lines. So here the lines are under the skin, so we don't see any pleura, anything, and these are again very characteristic of surgical emphysema. Then important thing is lung pulse. Now what is lung pulse? Basically lung pulse is transmission of cardiac pulse oscillations or cardiac pulsations to the heart. This will only be visible if the predominant movement of respiration is stopped in a particular patient. So if you intubate a patient, your tube goes on the right side. So on the right lung, you will see normal ventilation. What you see on the left side is only pulsation of the heart, because that lung is not participating in ventilation. So presence of lung pulse could be there in apneic patients. It could be there in endobronchial intubation on the other side of the lung. It could be there in mucus plugging, right? So there are specific indications when we say, when will you find the lung pulse? And these are various profiles that we determine with the help of lung ultrasound. I will not go in detail. It's an altogether, I would say, 2.5 hour talk on lung ultrasound. I'm just trying to be brief and, trying to tell you what all can we do with lung ultrasound. So we have various profiles depending on the pathology that the patient is having. So practical aspect, as I said, endobronchial intubation, one side would be ventilating, the other side would have a pulse. Then pneumothorax, very, very pathognomic of pneumothorax. There are very important signs, and this is one of the most important signs that you see in pneumothorax, what we call as a lung point. So lung point is the point where there is a breach in the pleura, which means this part of the lung is ventilating and this part of the lung is not ventilating. The importance of diagnosing lung point is, if I have to put an intercostal tube, right? This is the area where I would like to put, because this area corresponds to this schematic area. There is no lung. So the chances of damage to the lung tissue by your intercostal tube is less as compared to this area where the lung is actually fully expanded. So if you are putting an intercostal tube there, the chances that you will also touch the lung parenchyma is almost 100%. So that is the significance that we infer from this point. If you find lung point, again, it is pathognomic of pneumothorax with 100% sensitivity and specificity. And then we look at B lines. So what I told you, if they are increasing in number, your lung is worsening. If they are reducing in number, your lung is getting better. And this is as per the recommendations that have come up. In 2012, there were international evidence-based recommendations on lung ultrasound, where they said what is level A recommendation, and for every lung pathology, they came out with level A recommendation. And this was very important, that in patients with cardiogenic pulmonary edema, B lines should be evaluated, because it allows monitoring to the response of therapy, and lung re-aeration can be assessed by demonstrating a decrease in the number of B lines. So this becomes very, very important when patients with left ventricular failure step into their ICU. Lot of literature supporting the utility of lung ultrasound and actually replacing stethoscopes slowly and gradually. Important thing, consolidation. Now we always say consolidation means liver-like hepatization. So this lung is totally collapsed and it looks like liver. So this is one of the sign of consolidation. The pathognomic sign of consolidation is what is this? This is called as dynamic air bronchogram. The air is moving in and out. And this tells me that the entire lung is deaerated. The alveoli are obviously patent, and so the air movement can be seen. So if you see these points, and generally these are visible in zone 4, 5 and 6. So that's the reason I said always have a habit of turning your patient at least once and doing this scanning. You will definitely have these findings in patients who have some respiratory etiology. Then what we call as the shred sign, the superficial, the smoother part is what is consolidated, and this is still ventilated. So if this bright line keeps increasing upwards, it tells me my patient is improving. More and more lung is getting ventilated. If the smoother part keeps going down, 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 it tells me that more and more part is getting consolidated. So this is again the way you monitor your patients on a daily basis. ARDS, it's a non-homogeneous disease, and this is again pathognomic sign when it comes to diagnosing ARDS. And this is what we call as subpleural consolidation. Subpleural consolidation means just under the pleura. So this is where the visceral parietal pleura would be, and this is just under the pleura, small irregular lines, or what we call as the pleural line, and these are characteristic of ARDS, again called as subpleural consolidation. And there are various recommendations for it. Atelectasis, very simply you can diagnose. What happened in consolidation was the air was going in and out. In atelectasis, the air is trapped inside the alveoli. So there will be white dots in both the phases of respiration. So this is how you differentiate between atelectasis and consolidation. This patient will actually benefit from recruitment. So once you recruit these patients, there will be an aeration, and you will find that yes, my patient is doing much better. Pleural effusion, minor to massive pleural effusion can be easily diagnosed. So as less than 100 ml of pleural effusion can be diagnosed with the help of lung ultrasound to as massive as possible. Now this is a freely floating lung, and for people who have just started doing ultrasound, if you can put an M mode and you get this sinusoidal kind of pattern, this tells us that it is safer to drain this needle, drain this effusion by putting a small needle, because even with inspiration, the lung is not reaching the pleura. There is a gap, so which means even if your needle is placed, the lung will not touch the needle on inspiration. So that's the purpose of actually diagnosing pleural effusion. So to put all this together, there was a protocol which was named as Blue Protocol by Professor Lichtenstein, which said, first evaluate what is the sliding status. Is my lung sliding, as in there is a to and fro movement of the pleura, and if you say yes, then what is the status of the profile? Is it an A profile or a B profile? B profile means those vertical laser-like images. If they are bilateral, this is mostly a cardiac issue, so pulmonary edema. Whereas if you have a unilateral B line, it could be probably consolidation. Similarly, if you have bilateral A lines, always assess your DVT status, because in pulmonary embolism, the respiratory distress is not because of the lung, it is because of the heart. So always evaluate your cardiac status and you can have pulmonary embolism. Whereas if you have absent sliding with an A pattern, this is mostly pneumothorax if you are able to find a lung point. So they have tried to put it simply on a flow chart, that how do you look at acute conditions that step into your ICU. You can actually guide your ventilation. So we do PEEP titration, we look at recruitment, how much recruitment is necessary for a particular patient. We also look at mechanical ventilator related complications like ventilator associated diaphragm dysfunction that can be very easily assessed with the help of ultrasound with an excellent sensitivity and specificity. Obviously the patient has to be spontaneously breathing, not mechanically ventilated. The last important thing is you can also look at various kinds of shock assessment when you do with lung ultrasound, and this is called as the false protocol, which is limited by lung ultrasound. So what you do here is you look at an acute circulatory failure patient, you do simple echocardiography to assess what is the status of the heart and is there any free fluid around the heart leading to tamponade. If that is there, that is one cause of obstructive shock. You do your lung ultrasound, we looked at findings of pneumothorax. If that are there, again this is obstructive shock. None of these are there and there is an A profile sliding. You give fluids to this patient, and if on giving fluids your patient starts becoming congested with a poor heart function, you have a cardiogenic shock. If this does not happen and there is an improvement in the hemodynamics of the patient with the help of fluid, it means you are dealing with a hypovolemic shock. In case that does not happen, and again your lungs have started becoming wet, which means like a leaky capillary syndrome, you are looking at a distributive or septic shock. So this is fluid administration limited by lung ultrasound. So that's the name called as false protocol. So this is how you actually judge what kind of shock and what kind of therapy one should give with the help of lung ultrasound. Yes, it has certain limitations. As I said, it's a surface technology, so it cannot accurately detect the deeper pathology. So if you ask me, is there a bulla deep inside the lung? Sorry, I won't be able to tell you, because the moment it hits the surface, ultrasound hits the surface, it would start reflecting back. So I can't assess the deeper part. And as I said, it can't be used as an ultra diagnostic use with everything and anything belief. It has to be put together. Your clinical sense has to prevail. It has to be a complementary to each other. And yes, it requires some amount of formal training, some amount of experience, but still it has a very small learning curve. Obese patients with subcutaneous emphysema are difficult ones. You will have a lot of difficulty in assessing these patients, but still there are a number of windows that can be created to reach to a diagnostic conclusion. So it is an attractive alternative to bedside radiography. As I said, it does not have a very long learning curve, very short learning curve, huge cost and time saving potential. And once you have learned it step by step, it becomes very easy. You can actually inculcate this and put this as a routine protocol in your intensive care units, that every patient, irrespective of the diagnosis that the patient is stepping in, should undergo a head to toe ultrasound. Both the neuro ultrasounds, so TCD, cardiac, lung, abdomen, vascular access. So that assessment should be done on a daily basis. So we feel from auscultation, we are actually going to more and more into ultrasonation, and that's the new thing that one should go ahead with. Thank you so much.
Thank you. It was indeed a very nice deliberation of lung ultrasound. For me, it is a very useful tool day in and day out. Rather than more in ICU, even for our OPD patient is extremely useful. Patient is no heart failure patient or maybe improving or deteriorating. He comes to me, says that I have not had a good response to your therapy. You in 30 seconds do a lung ultrasound, look for B lines, and we always mention in our echo report that B lines are 4 or 5.
Right.
Now you see 6 or 7 or 10. We know that he needs more diuresis or more decongestion. Similarly, in ICU, when our patients have cardiogenic pulmonary edema, we look every day for that lung ultrasound. Combined with our echocardiography of E by E prime and doing a lung ultrasound, we come to conclusion that this patient requires decongestion or increasing inotrope, etc., etc. So it's a phenomenal tool. It's only a mindset that you need to change and forget that first line you showed, that the air is the biggest hindrance to ultrasound. Now we can say that air is the best friend of the ultrasound.
I agree.
Right?
I agree. Thank you.
Yeah, very well said, sir.
Thank you,
Ulmani
sir.
sir, very
I
well
would
said.
like to know how is the appearance in a solid mass in the lung or any cystic mass? How is the appearance?
So see, as I said, it's a surface technology. If it is inside the lung, I won't be able to comment it, provided the lung is non-aerated. So if let's say consolidated lung with a mass inside, yes, you can appreciate the gray-white differentiation. But if it's an aerated lung with a mass inside, we won't be able to comment. It's a surface thing. So moment it hits the pleura, everything reflects back.
Yeah.
Thank
Thank
you.
you, Dr. Sachin. I'll like to request you to proceed to felicitation area. So from here onwards, we move to our next inaugural ceremony, an official inauguration of the conference. And for that, I'd like to invite our conference inauguration. I'd like to invite Dr. Neha Agrawal and Dr. Rashmi Agrawal for handling the proceedings. Welcome, Dr. Neha and Dr. Rashmi. Over to you.
Thank you.
I request everyone to please take their seats as we are about to begin the inaugural function. Request everyone to please take their seats as the stage is being set up for the inaugural function. I also request all the past presidents of Nagpur SCCM to please occupy the front row. Guest of honor, chief guest. वो यहाँ पे सॉरी फॉर द डिले। इल्म की रोशनी जब मिलती है तो हर मुश्किल राह आसान लगती है। इल्म की रोशनी जब मिलती है तो हर मुश्किल राह आसान लगती है। सोच जब मिलती है नए मोड़ पर आकर तो इनोवेशंस का निर्माण करती है। महा क्रिटिकॉन बस एक सम्मेलन नहीं, कल के बेहतर क्रिटिकल केयर की बुनियाद बनती है। Hello and good morning to respected dignitaries, distinguished delegates, faculty members and dear colleagues. On behalf of the organizing team, I, Dr. Neha Agrawal, along with my colleague Dr. Rashmi Agrawal, extend a warm welcome to all of you for the inaugural ceremony of Maha Criticon 2025, organized by the Society of Critical Care Medicine, Nagpur. It's a proud moment for the Orange City team to host such an august gathering of eminent names in the field of critical care medicine from across the nation. The theme of our conference, Resolve, Involve and Evolve, beautifully reflects our journey in the critical care medicine, where we resolve to save lives. We get involved in every beat and breath of the patient, and we evolve through our rigorous learning, research, and innovations. And with that, we promise you to deliver cutting-edge knowledge and insights in intensive care during the next 2 days. So without wasting any further time, I request Dr. Rashmi to invite our dignitaries on the dais.
Moving forward, first of all, I request Secretary SCCM Nagpur, Dr. Utkarsh Shah, to escort our patron, Dr. Nirmal Jaiswal sir, on the dais. Next, the Organizing Secretary Maha Criticon, Dr. Sudhir Chafle sir, to please escort our patron, Dr. Nikhil Balanki sir, to the dais, please. And Dr. Kaustubh Upadhyay sir, our Treasurer Nagpur, ICCM, to escort our next patron, Dr. Rajan Barokar sir, to the dais. All dignitaries, please take your seat on the dais. जो हाथ थाम ले वे तो डर भी पीछे हट जाता है, जो हाथ थाम ले वे तो डर भी पीछे हट जाता है, गुरु के चरणों में झुके सिर को सफलता का मुकाम मिल जाता है.
I next request our organizing chairman Maha Criticon, Dr. Deepak Jeswani sir, and Chairman ICCM Nagpur, Dr. Ashish Gazre sir, to escort our chief guest for today's function, Dr. P.P. Joshi sir, and guest of honor, Dr. Vinky Rughwani sir, to the dais. Dr. P.P. Joshi sir is Executive Director, AIMS Nagpur, a teacher to most of us sitting in the audience. He needs no introduction. And a guest of honor, Dr. Vinky Rughwani sir, a renowned pediatrician and President of Maharashtra Medical Council. We welcome you, sir, to this conference. Thank you for gracing this occasion. आपका आगमन हमारे लिए गौरव का पल है. आपका आगमन हमारे लिए गौरव का पल है. आपकी उपस्थिति ही इस महफिल की शान है.
Next, I request Dr. Deepak Jaswani sir, Organizing Chairman, SCCM Nagpur, to please offer a floral welcome to our chief guest, Dr. P.P. Joshi sir. Now I request Organizing Chairman Dr. Ashish Gazre sir to SCCM Nagpur to please offer a floral welcome to our guest of honor Dr. Vinky Rughwani sir. फूलों की महक से स्वागत हम आज आपका करते हैं. फूलों की महक से स्वागत हम आज आपका करते हैं. इन नव कलियों के साथ अपना सम्मान व्यक्त करते हैं.
Let us now invoke the blessings of Almighty and commence the ceremony with our traditional lamp lighting and Saraswati Vandana. It has always been a symbol of knowledge, wisdom, and enlightenment for all of us, and it also reminds us of hope even in the most critical situations. I also request the past presidents of National SCCM, Dr. Kapil Zirpe sir, President-elect Dr. Pradeep Rangappa sir, to please join us for the Samay Lightning program. I apologize if I am missing any name, but if there are any past presidents of National SCCM, I request them to join the Samay Lightning program. Saraswati Namastubhyam Varde Kam Rupini Vidyarambham Karishyami Siddhir Bhavatu Me Sada.
Ya Kundetu Tusharahara Dhavala Ya Shubhravastra या वीणा वरदंड वंदितकरा या श्वेत पद्मासना या ब्रह्माच्युत शंकर प्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा. विचारसार परमा
May the flame inspire us to resolve. May the flame inspire us to all resolve, involve and evolve. Moving ahead, we now begin with the welcome address. A new chapter begins as we welcome the next chairman SCCM Nagpur, Dr. Ashish Ganjre sir, a leader whose vision shapes progress, as whose integrity inspires every step forward. I request everyone to welcome him with a big round of applause.
Good morning, everyone. Respected Chief Guest, P.P. Joshi sir, and Guest of Honor, Vinki Rugwani sir, the dignitaries on the dais, esteemed faculties, and delegates, my dear colleagues. It gives me a really immense pleasure to welcome you all on behalf of Society of Critical Care Medicine, Nagpur chapter for Maha Criticon 25. It's indeed really a proud moment for all of us in the Orange City to host his prestigious conference, which brings all together with the leading minds from across the states and beyond, and united by our passion for the excellence in critical care. This year theme, as told, is like resolve, involve and evolve. This beautifully captures our journey as an intensivist. As you know, we resolve to serve with dedication. We involve with ourselves wholeheartedly in treating patient care and as a teamwork. And we evolve continuously through our education, learning, innovation and compassion. As Maha Criticon has always more than a scientific event, it's a celebration of ideas, collaboration and the shared purpose. Our next 2 days, we explore new advances, challenges, established practice and reaffirm our commitment to providing a best critical care services to our patient. I take this opportunity to extend heartfelt appreciation to our organizing committee led by Deepak sir, Sudhir sir, our patrons Nikhil sir, Rajan sir and Nirmal sir, and my all-star team really for their tireless efforts in bringing this event in a life. My sincere thanks to also the national and the state ISCCM leadership and our faculty and sponsor and delegates for their enthusiastic participation and the support. As we begin this academic feast, let's carry forward the spirit of curiosity and the collaboration, and that defines our speciality also. I am confident that Maha Criticon 25 will leave us all enriched, inspired and ready to take critical care to the greater heights also. So once again, I extend my warm welcome to all of you and thank you for this. Thank you very much.
Thank you so much, Dr. Ashish sir, for those welcoming words and beautifully explaining the essence of this conference. It's now an honor for me to invite the organizing chairman of Maha Criticon 2025, Dr. Deepak Jeswani sir, to deliver his welcome address, a man whose steady patience, relentless efforts and deep commitment have brought this event to life. Sir, the stage is all yours.
Thank you, Neha. Good morning, seniors, teachers and my dear friends, dignitaries on the dais, Dr. P.P. Joshi and Dr. Vinki Rugwani along with patrons. It's my proud privilege as organizing chairman, the captain of the ship, to extend a very warm and cordial welcome to each one of you in this 13th edition of State Conference of Critical Care, the Maha Criticon 2025 at Nagpur is being organized by Society of Critical Care Medicine, Nagpur. We are truly honored to have amidst us our chief guest, Dr. P.P. Joshi, a teacher par excellence, a researcher, and a distinguished personality in the field of medicine, which adds immense value to the occasion like this. We also extend warm welcome to our guest of honor, Dr. Vinki Rugwani, We thank both chief guest and guest of honor who has graciously accepted our invitation to become part of this program in their busy schedule. On behalf of organizing committee, we extend a warm welcome to galaxy of star speakers which are there in this house for enlightening us in this academic fiesta of critical care medicine. And we will have academic meets, hands-on experience that we saw yesterday in the workshops. They were all full house in Datta Megi Medical College, and the guidelines are there to sharpen our clinical nuances. Maha Criticon 2085 has been conceptualized with objective to bring together experts, researchers and clinicians to share the latest development, exchange ideas and promote collaborative learning in the field of critical care medicine. Now over next few days, we will witness a series of thought-provoking talks in plenary sessions, interactive panel discussions on toxicology and trauma, thematic sessions from the basics to recent advances of respiratory, cardiac, ID critical care, neuro, metabolic and nephrocritical care. Along with this, we will have tribates also. We will have a critical care quiz in which 6 teams have been shortlisted. They have qualified for the final rounds, and these 6 teams are from medical colleges all across Maharashtra. The preparations for this conference started in January 2025 after we witnessed a benchmark set by our friend Ravindra Ghawat in the previous edition at Thane when he organized a bonanza of Maha Criticon 2024 at Thane. And we thought that we need to plan better in a better way to cross this benchmark. And I thank our patrons, Dr. Nirmal sir, Dr. Nikhil sir and Dr. Rajan Barokar, along with my able secretary for this conference, Sudhir, who pushed me hard, and I am honored to be elected as organizing chairman for this conference. Thank you for showing this confidence in me and granting me this opportunity. I was ably assisted for this mammoth task by a team of Maha Criticon members. We call it as Stars of Criticon. I am proud of your exceptional organizing team capacity, and actually you all are a shining star that I have seen in last 1 year working with you. We together can make this conference truly special, unforgettable, remarkable and a true academic festival. I have been fortunate enough to get assistance for such events starting from Central Province Criticon in 2014, which was led by Dr. Anand Dongre sir, and we had a team of 25 members of organizing team at that time, and now we are about 80 members in the organizing team, and believe me, they are truly dynamic, tech savvy, they are digitally fluent, innovative and they are absolutely focused. I request a big round of applause for dynamic stars of Maha Criticon. Thank you. Now, I will take your few minutes for journey of Society of Critical Care Medicine, starting from Dr. Arif Hussain, late Dr. Arif Hussain. He was founder chairman of ISCCM Nagpur in 1995, who sowed the seed with his young brigade at that time, Dr. Nirmal Jaiswal and Dr. Rajan Barokar, who were the think tanks of Arif Hussain sir. And sir pioneered the SCCM ship, and we salute and pay homage to you, sir. Then came Dr. Satish Dev Pujari sir as a chairman in 1997, my teacher, a physiologist, a pediatrician, a hardcore clinician. His work of biomedical forum, ABG app and indigenous ventilator is well known to everybody. Dr. Vilas Tambe sir, a magnanimous personality in himself, who took over the RIME in 1999 as a chairman, and he was the first person and probably till date the last person to organize a national conference of critical care at Nagpur, and he was ably assisted by Dr. R.G. Chandak sir. So a big round of applause for Dr. Tambe sir. Thank you, sir. He was followed by Dr. Nirmal Jaiswal sir in 2001, the dynamic chairman with a sky vision. The word impossible doesn't exist for him. The word impossible doesn't exist for him, and he initiated all the editions of Neurocriticon and International Critical Care Update, which become a biannual event that we organize every alternate year, and we will continue to do so. Following that, Dr. Ravindra Sarnaik in 2003 was the chairman. He was the first DM pulmonology of Nagpur. He was instrumental in bringing and integrating respiratory critical care in the central India. Dr. Rajan Barokar followed him in 2005, another icon of ISCCM Nagpur. He organized first conference of shock and sepsis in 2007, of which I was also a part. We are all delighted to witness Professor Jean-Louis Vincent and Professor Reinhardt from Belgium during his successful event of Dr. Barokar. Dr. Rajan inspired almost all of us in coming to critical care field, and he was the first edict from Central India. A big round of applause for Dr. Rajan Barokar, sir. Dr. S.K. Deshpande in 2007 is a perfectionist, idealistic chairman. He gave absolutely a shape to the organization. The record keeping and the accounts and the SOPs all were framed by Dr. S.K. Deshpande, sir, and he is very meticulous in following this till date. Followed by that, Major Devyani Buche, a military person in 2009, took over the RIME. She brought military order and organization to the branch. She at present is abroad, she's not available for this conference right now. Dr. Anand Dogre led us in 2011 with myself as his honorary secretary. We did a successful Central Province Criticon in 2014 with grand success. Dr. Narendra Rungta was president of ISCCM at that time. Dr. Dongre inspired the Nagpur team for further hierarchy at national level, and we got the Best Branch Award for the first time in 2015. Dr. Girish Deshpande in 2013 followed Dr. Dongre, and we popularly call him as Girish Guruji. He's a silent force with background experience of Dr. Buche. He finished all accounting backlog and Nagpur became IT born. We got a charity commissioner registration and we got a PAN card under his guidance. So a society became Society of Critical Care Medicine Nagpur. Previously it was called as ISCCM Nagpur chapter. Following that came Amitabh Bachchan, none other than Dr. Nikhil Balanke, with all multifaceted persona, academician, intelligence, warmth, extraordinary skills in organization, different events. He came in 2017 and he changed the academic scenario of the ISCCM Nagpur. He rigidly initiated journal clubs. He also initiated system-specific panel discussions, what he labeled as Samvad. And he also introduced a novel basic application, applied physiology, what is called as BAP. We used to discuss physiology and clinics in the same on the same stage with different specialists, and that was BAP which he initiated in the SCCM Nagpur. He also did a successful ID Critical Care Conference with Dr. Rajiv Soman sir and Dr. Camilla Rodriguez during his tenure. Dr. Jayesh Timane came in 2019, a prolific academician, Shashi Tharoor of Nagpur, and he propagated bedside medicine into critical care. He is very keen clinician. He was instrumental in getting Best Branch Award for consecutive 2 occasions in 2020-21. Dr. Kamal Bhutra, he was my secretary in my tenure. He came in 2021. He was very meticulous in proceedings. Unfortunately, his period of chairmanship was coincided by COVID. So there was not much of scope for physical activities, but he did lot of online meetings during his tenure. Imran Noor Mohammed, the IT man, the tech savvy, the handsome person of ISCCM Nagpur came in 2023 with passion for critical care, and he is a national level rifle shooter. He won a lot of awards. He is a personal coach for many of us. He is an inspiration for all of us. So at the end, I take this opportunity to thank all organizing committee members, pharma colleagues and event organizers. Himanshu, this was not possible without you all. My sincere gratitude to esteemed dignitaries on the dais, patrons, faculty members who will be sharing their valuable insights and experiences in coming sessions. We are confident that the conference will be memorable and intellectually stimulating experience for all of us. Once again, on behalf of organizing team, I extend my hearty welcome to you all and blessings from God Almighty, blessings from all our parents of organizing team. Thank you. Thank you very much.
Thank you, sir, for that wonderful introductory speech and bringing forward the rich legacy of SSCM Nagpur, and also for your leadership to bringing Maha Criticon 2025 to life. Now we have a good wish and a very special message coming here from our current national president, Dr. Srinivas Samavedam sir, as he could not be here with us in person today.
Over to the AV team to please play the video.
Friends, this is Dr. Srinivas Samavedam. I am the current president of the Indian Society of Critical Care Medicine. I am extremely pleased to know that the 13th Maha Criticon starts in Nagpur today. Unfortunately, due to some personal reasons, I am unable to make it in person for this conference, but I wish the conference all success. Maha Criticon has always been a much sought after conference in the country. Not only students and trainees from Maharashtra, but those from across the country look forward to this meeting due to its extraordinary content and the choice of speakers and the deliberations it delivers to all the delegates and those who attend. I wish the team all the best and hope this will be another successful Maha Criticon in the series of the state conference that is entered its 13th edition. Thank you very much. Have a good day.
Thank you, sir. Your absence is definitely felt, but your message carried the same warmth and guidance that we deeply value. Next, we have another special online message from Dr. Shirish Prayag, sir. Dr. Maha Criticon truly stands today as the brainchild of his vision. His ideas gave this conference its very heartbeat. Let's hear it from him. Over to the AV team. Please play the video.
Hello friends, this is Dr. Shirish Prayag from Pune. Welcome you all to the city of Nagpur for the Maha Criticon, this edition in 2025. The whole concept of Maha Criticon started almost 12-13 years ago. After we had completed the 2012 National Congress of ISCCM, we realized that in a national meeting, there were about 3,000 to 4,000 delegates. So compulsorily we had to have 6 to 8 parallel halls, which meant that the delegates had to move helter-skelter in multiple places. The faculty had to be diluted. The numbers rose, the financial burdens grew. So all this meant that the basic principle and the basic purpose of hosting a conference, of passing on knowledge to make sure that your next patient gets better care, was getting lost in the whole hullabaloo of hosting a conference. So we decided that the concept of critical care needs to be transmitted to the interior of a state. Finally, if a patient gets very sick, critically ill in the periphery, by the time he moves to a city critical care unit, it might be quite a bit of a time. And therefore, we need to make sure that at the peripheral hospitals, at small towns, at district hospitals, we need to erect the facilities of critical care, at least the basic ones. And the physicians need to be trained in these areas. So to take critical care into periphery was the target. And from that target, the birth of Maha Criticon took place. I'm very happy that over the last 12 to 13 years, the concept has traveled along. Nagpur, Kolhapur, Thane, Panvel. It has moved around quite a bit. Sholapur and Aurangabad. And people have been extremely happy in exchanging knowledge and views by getting the right faculty from all across the country. So as a part of this year's venture, is taking place in Nagpur, and I'm sure you are going to enjoy the deliberations. Please spend some time talking with the faculty, getting to understand, resolving your doubts, and making sure that you understand the newer concepts in critical care in order to make sure that your next patient is treated in a better way. Even if such conferences save some lives somewhere, I think the whole purpose will have been saved. So welcome again and hope that you enjoy this meeting. And I thank the organizers for hosting this wonderful conference and making sure that the right atmosphere is continued throughout. Thank you very much.
Thank you, sir, for that wonderful message and for giving us Maha Criticon to learn, share, and evolve. Moving forward to the most mesmerizing part of this conference, we have a humble request to our venue management committee. अब वक्त की कोई पाबंदी ना हो, टाइमर की कोई टिक टिक ना हो, शादी की शहनाई तो बज गई है, अब विदाई की कोई घाई ना हो। तो चलो आगे बढ़ते हैं बहुत ही सुंदर पल की तरफ और इतिहास के कुछ सुनहरे पलों को अपन पलटते हैं।
The Shadi comment was specially for Dr. Deepak sir. Throughout the meetings, he was always like, organizing a conference is like आपके यहाँ शादी है. You have to be that meticulous. आपको हर चीज का ध्यान रखना है. So it has all began with a big bang. You should just cherish the movement. And for that, he has an excellent idea of celebrating it by felicitating all our past presidents of Nagpur SCCM. Each one of them has contributed immensely to the growth and stature of SCCM Nagpur, adding new dimensions to the field of critical care medicine through their vision, leadership, and dedicated service. May I request all our past presidents to kindly come forward and grace the stage for their felicitation as we take their names one by one. I request Dr. P.P. Joshi sir and Dr. Venki Rughwani sir to please felicitate our past presidents. I also request the presidents to stay back on stage after their felicitation for a group photograph.
Our first president was late Dr. Arif Hussain sir. इन्होंने अपने हाथ से नागपुर क्रिटिकल केयर की नींव रखी। इन्होंने अपने हाथ से नागपुर क्रिटिकल केयर की नींव रखी। आंखों से तो ओझल हो गए पर यादों की महफिल में अपनी तस्वीर रखी।
Next is Dr. Satish Dev Punjari sir, a renowned pediatric intensivist. जिनके सपनों में इनोवेशंस का सॉफ्टवेयर चलता रहे, उनके टच से ही हर सोच को नया अपग्रेड मिलता रहे. He is a tech savvy, have many patents to his name, a renowned pediatric intensivist.
Next I invite Dr. Tambe sir, senior intensivist, an anesthetist with an intensivist calm side. He carries a rich heritage and builds healing spaces where others find life.
Next we have Dr. Nirmal Jaiswal sir, a stalwart of critical care whose wisdom leads the way, forever seeking knowledge from global updates day by day. More than a doctor, a true gem to all who cross his path. He masters every science, healing with skill and his heart's warmth.
Next I invite Dr. Ravindra Naik sir. From wisdom to precision, his expertise stands tall. A senior pulmonologist whose crisp knowledge inspires all.
Next we have Dr. Rajan Barokar sir. In the ICU, he leads with skill. On a Harley, he chases thrill. A pet-loving ECMO founder whose spirit refuses to stand still.
Next we have with us Dr. S.K. Deshpande sir. From silencing the storm in a beating heart to mastering the advanced critical care, his journey is pure precision.
Next is Dr. Devyani Buche ma'am. Strength of a soldier, skill of a seasoned physician, and the honor of being SCCM Nagpur's first woman at the helm. I think she is not with her today,
We move ahead. Dr. Anand Dongre, sir. Leader at the national level, leader at the bedside, and driving force behind Swastik Critical Care site. Sir is also not with us today. Moving forward,
Dr. Girish Deshpande, sir, a physician intensivist with skill and care, humble in heart and always there.
Dr. Deepak Jaswani, sir, a physician intensivist first in academic stride, mastering high-end critical care with wisdom as his guide. Humble and approachable, a family man at heart, a brilliant organizer setting every event apart.
Next is Dr. Nikhil Balankhe, sir, a physician intensivist with wisdom profound, a voracious reader where knowledge is found, with words precise and vocabulary rare, from a family of doctors with care beyond compare.
Moving forward, Dr. Jayesh Timane, sir, a physician intensivist shaping every critical care update, the force behind a batch that wins best award year after year straight in his tenure.
Next we have Dr. Kamal Bhutra, sir, an intensivist whose working is detailed and refined, an academician whose clarity and discipline sharpens every mind.
Dr. Imran Noor Mohabbat, sir, an intensivist with focus sharp and clean, a shooting medalist whose aim is always keen, a fitness and nutrition freak, disciplined and lean.
As we felicitate the past president, here is our current president, Dr. Ashish Ganzre, sir, an intensivist with dedication and administrator with vision. Approachable in spirit, grounded in nature, his humility completes his mission.
We request all dignitaries to please occupy the seat for a...
We request you all to please have a group photograph. All the past presidents and dignitaries on dais, please step forward for a group photograph. This movement needs to be captured. Seniors paving way for their future generations and future generation paying all the due respect to their senior presidents. Thank you so much.
Thank you so much, sir. We are deeply honored to have such distinguished leader among us. We now move ahead with the order of proceedings by announcing the prizes for e-poster and platform presentation competition. I request Chief Guest and Guest of Honor to present the awards to the winners. E-poster, I request all dignitaries to please occupy their seats on the dais. We are not going to leave you so easily. So moving forward for the prize distribution, our e-poster third prize goes to Dr. Lalit Kumar, a prize money of 5,000. I request please Chief Guest and Guest of Honor to come forward to give away the prize. Dr. Lalit Kumar. Second prize for e-poster goes to Dr. Lalit Khandarni, prize of 7,000 rupees. Congratulations, Dr. Lalit. The first prize of e-poster goes to Dr. Pallavi Walners, a prize money of 11,000 rupees. Congratulations, Dr. Pallavi.
Next, we move to the platform presentation prizes. The second prize is secured by Dr. Vishakha Khapekar, a prize money of 11,000 rupees. Dr. Vishakha. Congratulations, Dr. Vishakha. And the first prize for platform presentation goes to Dr. Ashish Nair. Dr. Ashish Nair, a prize money of 15,000 rupees. Congratulations, Dr. Ashish. Thank you, PP Joshi sir and Vinki Rugwani sir for giving away the prizes. We also had an interesting non-academic competition, Intensivist Got Talent. May I request our patrons, Dr. Nirmal Jaiswal sir, Dr. Balanke sir and Dr. Barokar sir to give away the prizes for the competition Intensivist Got Talent. The second prize is won by Dr. Mansi Ambare. I think she's not with us. Dr. Purva will be collecting the prize on her behalf. A prize money of 11,000 rupees. Congratulations, Dr. Mansi. And the first prize goes to Dr. Jyoti Bajaj, a prize money of 15,000 rupees for her painting. Congratulations, Dr. Jyoti.
This session showcased outstanding research, innovations and dedication. Thank you, patrons. This session showcased outstanding research, innovation and dedication from participants across various institutions. Congratulations to all the winners. Next, we have a very special moment. The book release on intensive care management of post-transplant patients, authored by Dr. Akhilesh Tandekar. May I request our chief guest and guest of honor to kindly come forward and do the honors of unveiling the book.
Congratulations, Dr. Akhilesh. We call upon Dr. Akhilesh Tandekar, sir, for this remarkable movement. Congratulations, sir, for this achievement. This book truly adds great value to the field of critical care and transplant medicine. The pride of Nagpur. Dr. Akhilesh Kandekar sir is from Nagpur itself. Now I request Dr. Yogesh Lakas sir, Chairman ISCCM Aurangabad. He has a small announcement to make.
Good afternoon, everyone. You can play the video. I will call my team, Chhatrapati Sambhajinagar, my secretary, my treasurer, my other members to the stage. This announcement is for the next Maha Criticon 2026 that will be hosted by Chhatrapati Sambhajinagar branch. Now, first of all, I'll call my team and I'll just say that the benchmark that started with Dr. Ravi Gawat and now that is on that step, Dr. Jeswani, Dr. Chafle, Dr. Ganjare, and all the Nagpur team has made a great benchmark for Maha Criticon. Dr. Shrish Prayak sir has definitely told that the Critical Care Society now, this has grown into a big tree and that the seeds were sown in 1993 and now we can see that the whole critical care academics that is getting penetrated into the interiors of all the states and we can now see that in the form of Maha Criticon we have made the change and we can see the unity of ISCCM faculties and all the star faculties as well as the delegates, they are enjoying the academics and when knowledge is passed to the next generation, that is the great asset for all of us. And with that agenda, the whole of Chhatrapati Sambhajinagar team will be welcoming you all at Chhatrapati Sambhajinagar in 2026. Can you please play the video? Yeah, it's on. It's a heritage site. The Chhatrapati Sambhajinagar, previously it was known as Aurangabad, the city of gates, and we have a great infrastructure there also that can host state as well as national conferences. And definitely all these delegates we would like to see, all these faculties we would like to see at Chhatrapati Sambhajinagar, and dates would be 27, 28, 29 November, exactly 1 year after this great conference that has been arranged at the city of Nagpur, and definitely I can see the efforts of the whole Nagpur team and definitely it has, and we could see that during the last 3-4 months how meticulously they were planning, and I can assure you all that my whole team would be doing the same efforts to have the great academics for you all next year, and all our faculties, our delegates, they will be interacting on that academic platform in 2026. And you could see that you have seen the Ellora Caves, Ajanta, the World Heritage. Many of you must have seen those also. And these are the great heritage sites. Then the connectivity is also very important and it is very well connected. And the Samruddhi Mahamarg, now that is connecting Mumbai to Nagpur. We have seen the marvelous that Samruddhi Mahamarg that was constructed under our leadership, our state political leaders, and that has definitely changed. I can tell you that in the 4 hours day before yesterday we could reach at Nagpur and city of Aurangabad, city of Chhatrapati Sambhajinagar. It is exactly at the center point of Maharashtra. From Mumbai to Nagpur, anybody can reach by road, by air, by all those things. And now these are the few of the conferences that recently, and many of the faculties, they have already they came to Chhatrapati Sambhajinagar then this is the sepsis summit that was recently, and 2025 year, that was very important for us. That was the silver jubilee we organized, and recently we had organized this master class of mechanical ventilation workshop that was attended by more than 150 delegates, and they really, that was transformed the journey of ISSM Chhatrapati Sambhajinagar. Thank you very much. We welcome you all 2026 on 27, 28 and 29th of November. Thank you for giving Dr. Jeswani this opportunity for us, and we'll be welcoming to you all, and we'll be seeing you there. Thank you, thank you, thank you very much.
Thank you, Dr. Yogesh sir and team, for that elaborate overview of the next conference. We look forward to it. And now we come to the most awaited part of the inaugural session, the words of wisdom by our esteemed dignitaries. To begin with, may I request our guest of honor, Dr. Vinky Rugwani sir, to kindly address the gathering. Dr. Vinky Rugwani sir is a dedicated pediatrician with a strong commitment for thalassemia and sickle cell patients. He is a distinguished leader involved in various organizations. He is the Prashashak or the President of the Maharashtra Medical Council. He is a member of Medical Advisory Board, National Medical Council. A President of Thalassemia and Sickle Cell Society of India. He has introduced online consultation and digital registration in MMC, which has made our life easier. He is the founder member of Thalassemia and Sickle Cell Center at Nagpur. We welcome you, sir, and look forward to your words. Over to you.
Good morning, all. On this occasion of Maha Criticon Nagpur 2025, sitting on the dais, Honorable Dr. P.P. Joshi ji, Dr. Ashish, Dr. Jeswani ji, all the dignitaries sitting on the dais, rather I will say the stalwarts of critical care medicine, and I can see even bigger stalwarts in front, and it's real delegates. See, you are having this conference, you had a workshop also yesterday, so you will learn a lot of things from this workshop. You all are well acquainted with this critical care medicine. I have been called here as a representative of Maharashtra Medical Council. So let me have few, interaction with you about Maharashtra Medical Council and its working. We all know that you people are actually representing modern medicine in the front line. And we all know that actually the science is, the medical is not only the science, but it's a commitment, it's a moral commitment, it's an ethical commitment. So we always say that we should embrace the code of ethics, code of conduct. We have seen in the history tells us that there are lot many, trending changes which are occurring in so many years. As far as the death is concerned, we all know that it is an unfortunate event. And we all critical care people are working in the vicinity of terminal stages of the patient. And in this particular, emotional moment we can say, or a confusion we can say, we people become the soft targets for the patient's relatives whenever there is a death. I tell you, in Maharashtra Medical Council, we used to get maximum complaints against the obs and gynec people few years back. But nowadays, the trend has changed. We are getting maximum complaints and there are maximum litigations against the critical care people. So this is very, challenging and worrying part as far as you people are concerned. But you all know that there are always a ways to mitigate such type of litigations. We all know that the two important things, one is communication and second is documentation, which are the most important things we should always think of, we should always take a precaution of it. Now, as far as medical council working is concerned, we are trying to bring the few new things in it. Now, in recent past, what we have done is, we are trying to sensitize the police personnel, right from the constable up to the commissioner. We always want them to know whenever there is a complaint against the doctor, there should not be any harassment of doctor. So for that matter, we have initiated the district level seminars with the police people. We have already done it in Pune, we have already done it in Solapur. We will be doing in Nagpur also and other districts. Rather, I will like to have inputs from you people also in such type of events and seminars in the conferences. Now, you all you have to do some communication with Maharashtra Medical Council for your registrations, for your renewal of registrations, for the conferences, for the credit points and all. So we are trying to make it is doctor friendly. We have digitalized the whole process now. Now we have strengthened our IVR system. Recently we have brought this WhatsApp chatbot system also. So we are in the process of making MMC very friendly so that you all should not face any issues as far as the council is concerned. I always, whenever I go to any, medical fraternity people, although you people are quite experienced people, you are doing so much of good work in the background, but I always feel like telling that we as a profession are doing a wonderful job, but at the same time, we should always have some commitment, some social commitment in our life. As I tell you, as was introduced, while introducing me, it was said that I am working for some thalassemia and sickle cell patients. I tell you that I feel so happy whenever a parent of a patient of thalassemia comes to me and tell me that, Doctor Saab, आपने हमारे बच्चे का निशुल्क बोन मैरो ट्रांसप्लांटेशन करा दिया, हम आपके बहुत आभारी हैं. Really, I tell you that the time you hear such words, you feel like दुनिया में इससे ज़्यादा खुशी नहीं मिलेगी. आप मेडिकल काउंसिल के प्रेसिडेंट हो या कुछ भी हो, ये पद कोई वैल्यू नहीं रखते अगर आप समाज को कुछ नहीं देते. तो I request you that we should all keep one thing at least in our mind, that we should serve the community. I thank Dr. Deepak, Dr. Ashish and all the organizers for having such a wonderful and useful conference and giving us an opportunity to interact with you all. Thank you. Namaskar.
Thank you, sir, for those enlightening words. Medico-legal aspects are really something we should all ponder on, and thank you for guiding us on that. Now I request all the dignitaries on dais to please felicitate our guest of honor.
Now, may I request our chief guest, Dr. P.P. Joshi sir, to grace us with his words of wisdom. Dr. Joshi sir is a senior physician with over 40 years of experience in the field of medicine and research. He has been a mentor to almost all of us. He has many 217 plus publications in national and international journal, earned many prestigious awards like Rockefeller Foundation Fellowship and founding member of India Clan, led AIIMS Nagpur to become one of the Central India's first government hospital register for heart transplant. We eagerly wait your insights, sir.
Thank you very much, and namaskar. A very warm welcome. Good morning to all of you, dignitaries on the dais, big people, big intensivists, Dr. Nikhil Balanke, one of the pioneering physicians and an intensivist, Dr. Deepak Jeswani, the organizing chairperson, then the organizing secretary, Dr. Safle, Dr. Rajan Barokar, one of the first intensivists of Nagpur, Dr. Nirmal Jaiswal and Dr. Barokar. I remember them as working with them in IGMC. And then they were the first people actually to start intensive care in Maharashtra, in Nagpur. And a lot of other dignitaries, chief guest Dr. Vinky Rugwani, and a lot of dignitaries of the dais, all the past presidents, Dr. S.K. Deshpande, my batchmate, Dr. Tambe, who is the very senior, one of the first persons to start an intensive care hospital here in Nagpur. And all the other past presidents, Dr. Satish Devpujari has left, I think. And so it's been a great galaxy of intensivists of Nagpur, and it's a great pleasure to be called here as a chief guest for this 13th Maha Criticon conference. And I'm sure under the leadership of Dr. Deepak Jeswani, this would be a grand success. Well, intensive care has in fact flourished or has grown in the past few decades, 2 to 3 decades maximum. Before that, in our times when I was doing post-graduation, there was only one intensive care, which was started very recently as I joined my residency. It was mainly for heart attack patients, intensive care for heart attacks, but it was ICCO. And then there has a small place for medical intensive care. Now we have intensive cares for all subspecialties. We have in the AIIMS Nagpur, we have started we have 105 intensive care beds. In addition to the medical intensive care and the coronary intensive care, there is a very well-established surgical intensive care, neurosurgery intensive care, then pediatric intensive care, neonatal intensive care, trauma and emergency intensive care. So a lot of branches and a lot of places. And postgraduate courses have also started. There's a lot of things have evolved over the past few decades, and Nagpur has now become a very good center with a lot of trained specialists and good care for intensive care. And it's a very warm feeling to see the growth of intensive care in Nagpur in the last few decades, 2 or 3 decades. Before 1990, I don't think there was any good facilities available. Of course, Dr. Arif Hussain had started this intensive care about 3 decades ago, but then the number of people who are now going in for intensive care is tremendous. I'm told there are 800 registrations for this conference. It's a huge number, and there are more than about 20,000. And the credit all goes to Deepak Jeswani and the organizing committee for having registered more than 800 delegates, and along with students and along with postgraduate students and others. People coming from all over, not only from Maharashtra, but all over the country. That is the credit, all of course, goes to the organizing committee. It's also very important to understand that critical care is an expensive proposition. I mean, if you see the common person, common man, uh, getting treatment in a private setup in intensive care many times is very difficult. I also understand that to set up an intensive care, a lot of funds are needed. It's very expensive to have all those world-class equipments, high-end equipments inside the intensive care. They're expensive. To run the ICU also, where there are a lot of expenses. And naturally, these expenses in the private setup have to be borne by the patient. But the number of critical care patients, there has been beds available in India. There is a gross discrepancy in the sense that they're unevenly distributed. There are more in the private setup, less in the public setup, less in the government setup. There are more in the urban areas, less in the rural areas. So this type of skewed distribution is there of critical care beds, and this needs to be addressed. And also it's very important to address the issue of how to overcome the expenses and how to give context-specific and treatment, and how to reduce the cost is something which we should, all of us need to think. Of course, in a government setup, in AIMS, we have more than 105 intensive care beds. There, the charges are very, very minimal, and patients who fall into the MJPGY scheme and those who are in BPL category are getting free treatment, even in intensive care. And therefore, we are as such committed to provide affordable and accessible care to the poor people. But the number of beds, even in the government setup, intensive care beds, are very less as compared to the demand. And I'm told that there are about 30 lakh intensive care beds in India, which has a population of 1.4 crores. So these are very less beds. And therefore, and the treatment of intensive care is very less. The number of people who are trained in intensive care, who are trained to give intensive care treatment, critical care treatment, again, the number of people are less. And again, there are more in the urban areas, very less in the rural areas. And as has been told by Dr. Shirish Prayag in his talk, it's very important that this type of basic critical care training should be given to people in the rural areas. We have been giving in PICU and NICU, which is run by Dr. Banait in AIMS Nagpur, have adopted Dharani, which is in Meghat, which is distant. And we are doing teleconsultation. Our team has, with the help of PATH NGO, we are going there. The team from AIMS Nagpur went to Dharani, trained the nurses there, did the gap analysis. And then we called the nursing staff as well as the doctors from the very few doctors, but mainly nursing, to our setup and trained them there, so that their 8-bedded NICU, which is there in Dharani, they get good, proper evidence-based treatment. Similarly, and then continues on a daily basis, teleconsultation is being done with Dharani people, and this has resulted in a very dramatic improvement in decrease in mortality, decrease in referral rate to Amravati, decrease in sepsis, and the overall has shown results, and this is due for publication also. Similarly, we have adopted the Gadchiroli district, where people from AIMS Nagpur have visited and did what is known as the gap analysis. You'll be surprised that there is a lot of equipment. It's easy to buy equipments for the government, but you need trained manpower in the rural people area. That is not there. Even the nursing staff there did not know how to put a mask or how to give oxygen. So this type of training is absolutely essential at the peripheral level in the rural areas. And we have done that kind of gap analysis, and we are training the nursing staff also how to deliver oxygen, how to do basic intensive care. And this is something which I think the society as a whole should take up as a challenge of improving the care and reaching the public in the rural areas to improve the care of intensive care in the rural population. So that is, and training the nursing staff and do not be restricted only. So this is maybe a part of the agenda of the intensive or critical care society. So this is, also it's very important that it is not only doctors which are important, but also paramedical staff, which require very important training, which is also a very important part. And that attention of training of these paramedical staffs are also very important. So, in fact, we are running a DM course in neonatology, NICU, we are in neonatal intensive care, DM course in pediatric intensive care, and a lot of PDCC courses in intensive care, critical care. But these number of people who come out are much less, and number of trained intensivists are much less. They need to improve. This ratio needs to improve. Ratio of intensive bed to population needs to increase. Increase in manpower has to increase. Again, context-specific, resource-sensitive research is necessary to find out which strategies work in improving the outcome. I am very happy to have that you have called me as here as a chief guest to deliver this talk here. But I would like to thank the organizers again. And I've been told the conference has been organized in a very complete manner. They have got best paper award sessions, quizzes there, debates are there, and not only that, non-academic activities like paintings and other things who have been awarded. That is also a very unique concept which has been added, and of course there is a cultural evening also. So it's a big back of package which has been integrated into this conference, which promises to be a very entertaining both academically and culturally also. And thank you very much for calling. Thank you very much.
Thank you, sir, for those truly motivating and thought-provoking words which will guide us forward. May I now request all dignitaries to come forward to felicitate our chief guest. Dr. P.P. Joshi, sir.
A ceremony would be incomplete without the vote of thanks. So as we come to the conclusion of the inaugural ceremony, I now invite the organizing secretary, Maha Criticon 2025, Dr. Sudhir Chafle sir, to deliver his vote of thanks.
A very good morning to all. The respected dignitaries on the dais and off the dais, esteemed speaker, respected teachers, my seniors and friends. On the behalf of Maha Criticon 2025 and SCCM Nagpur, I would like to extend our sincere gratitude to each one of you for making Maha Criticon 2025 a resounding success. First and foremost, I express my sincere gratitude to Honorable Dr. P.P. Joshi sir, the CEO and Executive Director of AIIMS Nagpur, for his kind acceptance to grace this occasion as a chief guest. Sir, we really appreciate your support at every event and always supporting and guiding us. I am also grateful to our guest of honor, Dr. Vinky Rugwani sir. He is a Prashashak of Maharashtra Medical Council to accept our invitation in spite of his busy schedule. We would also like to thank our esteemed speakers and expert panelists who are going to share their expertise and insights next 1.5 days, and which will definitely add immense value to our conference. I take this opportunity to express my deepest gratitude to all our teachers, advisors, and past presidents for their wholehearted support, guidance, and blessing. I extend my sincere thanks to all office bearers, executive members, and organizing team members for their dedication, commitment, and support. I also appreciate the presence of Dr. Anup Mara sir as an MMC observer and his help in organizing the workshop yesterday. My special appreciation and gratitude to all delegates. Without you all, it is really impossible to make this event a grand success. To all our sponsors, event manager, the Prism, especially Himanshu, the Hotel Center Point, we express our heartfelt gratitude for their support and collaboration, which has been instrumental making this possible. And finally, I am grateful to our MOCs, Dr. Neha Agrawal and Dr. Rashmi Agrawal for coordinating and conducting this program flawlessly, and I think they deserve a big hand of applause. Once again, thank you all, particularly those who I may miss unintentionally, and have a grateful day and enjoy this academic feast. Thank you very much.
Thank you, sir, for expressing our collective gratitude so gracefully.
आरंभ तो एक नींव है, मंजिल अभी बाकी है। आरंभ तो एक नींव है, मंजिल अभी बाकी है। अभी तो सिर्फ दीप जले हैं, महाक्रिटिकॉन का सफर अभी बाकी है।
तो आइए चलते हैं इस महाक्रिटिकॉन के सफर पे and let's enjoy 2 days of cutting knowledge together. With that, we formally conclude the inauguration ceremony of Maha-Criticon 2025. May the spirit of our theme, resolve, involve, and evolve, continue to inspire us throughout the conference and beyond. Thank you, everyone, and have a wonderful day ahead.
Now we move forward to another most esteemed moment of our conference, the oration ceremony. This segment celebrates ideas that shape our field and honors voices whose work lights the way forward.
For that, we have an expert panel with us. May I invite our expert panel, Dr. Vilas Tambe sir, a senior physician intensivist of Nagpur. Dr. Sanjay Jain sir, senior physician intensivist practicing at Nagpur. Dr. Pradeep Rangappa sir, President-elect National SCCM. Dr. Kapil Zirpe sir, past National President and a senior consultant at Ruby Hall Clinic. And Dr. Sameer Zog sir, a senior consultant intensivist at Dinanath Mangeshkar Hospital. I request our expert panel to please
Dr. Tambe sir, please. Dr. Sanjay Jain sir, Dr. Kapil Jirpe sir, Dr. Rahul Pandit sir. Yes, sir, this sir.
I request the expert panel to please occupy the seats on
the dais. Dr. Pradeep Rangappa sir.
सर तुमचं पण नाव आहे.
While we set the stage for our esteemed panelists, I request Dr. Jayesh Timane sir to introduce our esteemed orator, someone who brings scholarship, clarity, and a depth of experience that inspires both seasonal professionals and young learners alike. I request Dr. Jayesh sir to reveal his name and introduce him.
Hello. Yeah. Good morning, everyone. Today's speaker who's gonna speaker for the oration is Dr.
Dr. Jayesh sir, may I take a moment for the expert panel to occupy the seats on the dais? Just a moment. I again. Yes. I again announce the name of the expert panel. Dr. Vilas Tambe sir, Dr. Sanjay Jain sir, Dr. Pradeep Rangappa sir, Dr. Kapil Zirpe sir, Dr. Sameer Zog sir, Dr. Rahul Pandit sir. I request our organizing secretary to please escort them to the dais.
एकाकडे ती
Over to you, Dr. Jayesh.
Yeah, good morning, everyone. I've been bestowed upon the responsibility of introducing Dr. Nirmal Jaiswal, sir. It is really an honor. I know him since more than 2 decades. Dr. Nirmal Jaiswal, sir, is MBBS and MD from IGMC. He is truly an IGMC man and is very proud about it. He's a distinguished senior physician, an intensivist with over 3 decades of unwavering commitment and excellence in internal medicine and critical care. A true physician at heart with a love for critical care. A trailblazer in the field. He has seldom left any of the cases unturned, unsolved. He's credited with establishing one of the first dedicated critical care units with internal medicine background in central India, significantly transforming the region's approach to the emergency and the intensive care. He's a visionary educator, mentor. He has shaped the careers of countless people who has worked along with him. To top it all, he has been honored with several accolades and including most prestigious Chikitsa Ratna Award. He continues to serve the respected and he's continued to serve the critical care and is a respected national faculty and a thoughtful leader who is passionately advancing medical education and critical care practices across India. Having said that, there are a few words which I would like to say from my side. We know him as a critical care physician and he's a very nice and he is very good at his work. He's a very humble man, a stoic and brave in his exuberance, a man who has almost kept all the words he has said. He is kind of the person who would want you by your side in your most difficult moment at any point of time. A stoic man and a brave man who has always continued his work, be it in the hospital or outside, with commitment. Ladies and gentlemen, let me present to you Dr. Nirmal Jaiswal, sir, for his oration.
A big round of applause for Dr. Nirmal Jaiswal, sir. All of the audience, please.
Thank you, Jayesh. Thank you very much for your kind words. Respected Chairperson, Dr. Rahul Pandit, Dr. Rangappa, Dr. Kapil Zirpe, Dr. Sanjay Jain, my esteemed colleagues, my fellow intensivist, which is sitting in the hall, it is really both an honor and privilege to stand before the galaxy of the minds, which definitely have in their mind to save the critically ill patients. Today's oration possesses a deceptively simple but deeply layered questions which is hemodynamic monitoring, where we are. Let's take a walk with me what has happened over a period of time in so many decades with the hemodynamic monitoring. This is a history. We started with William Gans and the Swan. In those era is called as pressure era, where the CVP, MAP and PAC, the early morning monitoring triad that defined the critical care in the beginning of the critical care medicine. In 1980s and 80s and 90s, the Swan Gans was introduced by these two fellows, the Gans and the Swan. The core physiology was, whenever the patient was getting sick, you are supposed to know what is happening in the body. So what are the pressures and the pipes, what their pressures were inside the body, so that we can monitor the hemodynamics, and accordingly we can treat the patient so that we can save that particular life. That was the basic concept to launch what you call it as Swan Gans catheter. The monitoring meant the measurement that in those decades and not necessarily improved outcomes. It was just the beginning of the hemodynamic monitoring in the intensive care unit, just to know what is pressure and just try to follow those pressure to save the life of the people. And this is the era of pressure and pipes. The beginning when numbers ruled the bedside, means like the Swan Gans or the CVP or the map, they give the information regarding the pressures in the body. So, and there are the numbers definitely. So the early focus was to start with CVP, MAP, pulmonary arterial occlusion pressure, which dominated the particular era of 1890s. The PSC introduced during that tenure around 80s and 90s, and measurement versus the interpretation was the basic, what you call it as dilemma, what is to be believed or what is not to be believed. In that scenario, what has happened, but the reality picture was whether we should believe on the pressures, what the numbers, what we are getting from the monitors, and if you try to follow those numbers, it was very difficult to save that particular patients. That is the most important, what you call it as negative aspect that particular decade which has happened. And see what has happened later on. This concept which really ruled almost like 2 decades or 3 decades. So there was a challenge to this particular concept of monitoring the patient with the numbers. It was all physical numbers what we are getting from the monitors. So there was the big trial came up in 2005 which was published in Lancet. That is Pacman trial. Jose Jacques was the main author along with his own colleagues. Demonstrated as far as his trials were concerned, there was no mortality benefit whenever they used the PAC catheters in the patient. Another trial was an ESCAPE trial. That is JAMA 2005, it was published. And Mitchell and Mayank Goyal and et al. Demonstrated no improvement in heart failure outcomes with PAC guided catheter. Again, the support investigators in JAMA 1996, Connors et al., almost like 5,000 and odd figure, they have shown that there was a high mortality rate with the PAC catheter. The catheter which was very long, not only the PAC catheter which was showing the numbers, but at the same time it itself have their own complication in the setting of the ICU. So there is, whatever the concept was around 2 decades, whatever they have mentioned, whatever they have really did the great job, because nothing was there in the intensive care specialist hand. So the numbers were followed and accordingly the patients were treated. But definitely with these 3 trials, the Pacman trial, the support investigators group which has presented, and the the ESCAPE trial, there was definitely the fall because the people started listening. Intensive care people across the world started following that particular trial and started thinking whether really we should follow the numbers or we should do something else. So as a history wise, 1970, again there is a high-tech monitoring with the numbers. The another is what you call it as in 1990s, the peak usage of the symbol of the sophisticated ICU. Whenever there is a use of this Swan Gans catheter, it was supposed to be called as the high-tech ICU. That was those era was there that time. But at the same time, in 1996 to 2005, these trials has really downgraded that acceptance of what you call it as the Swan Gans catheter and the numbers what we were getting from those particular trials. So the critical lesson from those particular trials is expected to reduce the mortality, but never it didn't reduces the mortality. The era taught us the humility, and because the data was not matching with the decision making of the clinicians. So what is the basic of this, all this concept is the physician, means like man behind the machines are very, very important, because whenever you gather the number, at the same time you are supposed to interpret, it needs a human. It needs a critical care consultant how to go ahead. And that was not matching, because whenever the numbers were there, it was overzealously treated by so many things, and the patient is to go on a patient who is coming with a not ventilator, but he is going on a ventilator, ultimately patient is to die. So that's the reason in present era what we are declaring the use of this Swan gas catheter. So humility, learn from these particular things. Now lesson from the pressure era again, the pressure was not matching the perfusion. That is another concept which has come up. Whether we are really treat the perfusion or we should see what is happening with the, pressures or what is happening with the pressures. So the another problem was CVP, MAP and the pulmonary artery occlusion pressures provided only the snapshots. They were not having the what you call it as ongoing real-time values, so that we cannot come to the conclusion what is happening. And after this scenario of this so many trials, after some few years, and there was a shift, total shift, whether we should treat the numbers or we should have the real-time hemodynamic monitoring. So it starts from pressures to flows. The dynamic era begins. The question started asking of the indicators what we are getting from the numbers from the monitors. The dynamic parameters came in the picture. That is the stroke volume variation, the PPV, the PLR, the IVC measurements that has been introduced by the Tebul and the Monet. We were very, very lucky. We were having in the last intensive care unit, the International Critical Care Update. These all two people were here who started this notion across the world from their centers. And it was mesmerizing to listen to them, the real authors of this concept. The technology meets the physiology, means like rather than seeing the numbers, you are supposed to see the physiology of the body, so that we can tailor-made the protocols for that particular patient. So ultimately the concept came, it should be the patient-centric approach and not the numbers. And this is the turning from static, that is what you call the numbers, what we are getting from the patient, so from the monitor, it is the dynamic, like real-time values what we are getting. So the CVP, still we are using the CVP, the basic parameter, right? CVP, so that arbitrarily it can give rise to a little bit idea about what is happening in the system of the body when the patient is coming to your ICU. And another is the POP, that is the pulmonary artery occlusion pressure. These are the two most important things. Still we are using, I am using because I am those particular area. But the selection of the patient is very, very important. Not every patient should go on that particular Swan gas catheter. So this is not being used now, and it is not dependable because it is varies from patient to patient depending on the situation, physiology of the patient as well as the lung parameters are concerned. So these are just gone. Now what is there? The numbers started moving, means like we are getting the dynamism, we are getting the real-time number. So what is that? Which measures the physiology response to the control changes rather than the isolated pressure value. Whatever you give, the numbers are going to change, and accordingly you are just supposed to stop or you are just supposed to reverse it so that the patient will not get deteriorated. Then the snapshot era has definitely gone away and the evidence-based revolution has come up. Lot of papers have come. I'm really thankful to this Professor Tabol, who is from the Paris, and is really enlightened us on this particular ground. So the physiology is the key management to treat the physiology to get the reversal of that particular sickness or the critically ill status of the patient. So the science of the volume responses have come up. There's something like, if you remember or if you just recollect, the early goal dilated therapy in the first 3 hours of the management of the sepsis in that scenario. So the physiology is the most important thing. If you just follow that particular fixed protocolized treatment, the patient is to get worsened. So you are supposed to follow the very well established what you call it as the principle, that is the Frank-Sternil mechanism. This is the most important thing. You are supposed to learn this particular Sterling principle, Frank-Sterling principle, learn by heart. You will not going to mess up the patient in the first 3 hours of the that sickness of the patient in the emergency room itself. What are the prerequisites of this Frank turning? One is the most important. Patient should be on the controlled mandatory ventilation with adequate tidal volume. That is the most important thing. Another is the normal sinus rhythm without arrhythmias. That is the most important thing. Another is the closed chest condition. This is one. And the absence of the spontaneous breath. Means the patient has to be paralyzed to get the proper physiological values from the patient from that particular modality, whatever you are using. So the critical principle is the interpretation depends on the understanding physiology and not just reading the equipment displays. That is what you call it as numbers. We don't do the monitoring of the numbers, and we don't do it nowadays since almost like a decade now. We treat the real-time values what we are getting. So the dynamism has come in the action now. So what are the bedside? What are the game changers? What are the bedside game changers of this? One is the passive leg raising with 2D echo facility. That is the most important. What is the importance of this passive leg raising? If people are not following this, start doing this, because it doesn't need the fluid to administer. It doesn't need the fluid to administer. You are just supposed to do the manuals. The fluid automatically goes from the lower extremity to the heart, and you just get the values from your 2D echo parameters, and you will just see whether the patient is fluid responsive or patient is not responding to the fluid, so that you cannot further damage the further physiological process of the patient of that particular disease. Another is stroke volume variation. That is another most important. This is the respiratory induced changes in stroke volume during the mechanical variation. The threshold is around 12 to 13%. Indicates fluid response in appropriate patient. And the last is the most important, is the PPV, that is the pulse pressure variation. The cyclical changes in arterial pulse pressure with the ventilation, similar threshold and the limitation as a stroke volume variation, but the derived from the arterial waveform. That is almost like what you call a non-invasive technique of rather than going for the invasive technology. One is the what you call as the echo. What I am seeing here is the echo. Another is the what you call as PPV. Another the passive leg raising. If you just combine all three together in the first 10 to 15 minutes, then you will get the real time what is happening with the patient, and the patient can be saved rather than putting them in the complications. Rather than a decade back, what we used to do, BP come hai to just give the 300 bolus, right? And just try it. If the patient is coming up, the BP is coming up and going down again, give 300 bolus, or maybe down the line, whatever depending on the patient's status that particular time. But those days have gone, because we have seen on our days, our eyes, like patient has deteriorated further. So coming back or coming again further is something like macro hemodynamics. What is macro hemodynamics? Is the blood pressure, what we call it as the vital signs, the blood pressure, the cardiac output, and the central pressure. That is the macro assessment of that particular patient at that particular hour when you are examining the patient in the emergency room. But that is not sufficient. The investigators again has gone towards not only the measurement of what is happening, but the perfusion. So when the perfusion is needed, then only the patients are going to survive, because it will tell you whether the patient is, what the patient status or the physiology of the patient of that particular time. So what is the most important? Bedside technique, that is the capillary refilling, that is the skin mottling if it is present, or the lactate clearance. These are the three major important ingredients of the microperfusion. And if you manage both the thing together in a one site, that is macro as well as micro, then you are definitely going to get the positive outcome from that, whatever you do that particular patient in that particular hour. And there was a big trial on this, the evidence base, that is Andromeda shock trial, and this has proven fact. With this concept, if we try to manipulate or try to jugglery on that particular patient who is coming to sick at your casualty, then definitely you are going to win at the end of the journey. What we learn, again, I don't want to repeat the same thing. The modern landscape, that is the hemodynamic monitoring, is the basic key factor or basic management for any disease or of any system. What you need is if the patient is in shock. means shock is equal to all the flow charts start flowing. That is the most important. So to manage that, we used to have the invasive, we still have. We have now the minimal invasive and we have the non-invasive technique. Non-invasive technique definitely preferred because as you know, the invasive or maybe minimally invasive techniques, they definitely on a long run down the line after 4 to 5 days, they themselves give rise to nosocomial infection. So that is another hindrance in management of the system. So in that scenario, non-invasive techniques is always preferable. But definitely, it is very, very costly affair at this point of time. So we are stuck to the minimally invasive and we are using in Nagpur as well as corporate city. These people definitely have, they are from the big hospital, corporate hospital. They themselves have all these gadgets there in their ICU. So the minimally invasive system, what we have is a flow track, is a PICO, is a lead code. These are all systems which are available if you can just really try to save the patient's life, definitely you are supposed to use these monitors and you will be amazed. Whatever, in the first instance you started with the fluid, say for example, you start going for the 2D echo and along with the POCUS and you come to know that patient doesn't need the fluid, you start the vasopressors. And you believe we have treated this patient, we could get rid of the vasopressors as fast as possible without infusing much of a fluid. So the non-invasive revolution has come as far as the monitoring is concerned. The another is the NICOM technology. It's a bioreactance based cardiac output monitoring. But you don't have to, you are just supposed to put the finger in the monitoring system and you will get the non-invasive technology. By the non-invasive technology, the cardiac output on the screen, the same like ClearSight. So it has really made the intensivist life very easy in the first go, in the first hour of the management. If this sort of monitors we try to get rid from the system, from our own setup, then we definitely try to reduce our mortality. The point of care, POCUS, yesterday was the big success about the POCUS workshop. So everybody, every physician, every anesthetist, or maybe the registrar of the ICU or the duties people who are doing in the ICU, so they should know what is the POCUS. And you will come to know like your unit has really gone ahead of what it was. So the another man, the D. Baker, I was talking about the Tabul, I was talking about the Monate. Now the D. Baker has a lot of papers coming out, not only on ventilator but also the physiology also at the same time. They have just gone ahead more than the blood pressure, the macro integration. Means like ultimately what we are supposed to see the physiology and at the same time treat the physiology accordingly to avoid the complications of that. So what is the ultimate thing has come up? It is something like individualized decision making. You are not supposed to follow what the protocol of the AGDT was given in the sepsis protocol, right? Every individual is different. Every management is different for that particular patient, and accordingly you are supposed to go ahead. Because it is not my experience, it is the landmark trials which has come in the system, and it is the evidence base, right? It is the evidence base. Coming to the case, after listening my talk, coming to the case, the BP is 80 systolic of one of the patient. MAP is 65. The current trend is the 65 MAP is mandatory. The CVP is 8 centimeter. So this line, the first line says patient has a hypovolemic shock. But at the same time, the MAP is 65. So people don't see the MAP. People only see the systolic BP. You should see the MAP. MAP is necessary for the perfusion of the system, right? So CVP is 8. That is also normal. Means if you don't know this value, RMO on the duty gives the fluid. So ultimately patient will land up in a pulmonary edema and patient goes on the NIV initially and then go on a invasive ventilator. So it is a very nightmare sometimes, and you just start shouting on the RMO what you did it. Because that's the reason why the POCUS workshop was mandatory for our RMOs also, even if they are BMS. We really wonder when Nikhil and Rajan were talking about, a lot of MBBS came from the Nagpur and around Nagpur city. Where they have gone, we don't know. They are just moving around what their Gen Z, they don't have focus at all. right? Another case, right? So it is septic shock, right? Cardiac output is normal, 4.2. MAP again, 65. Lactate is very, very high. In that scenario, if you give the fluid, again it will worsen. You are supposed to start the inotropic agents rather than giving the fluid. As you know, bottom of the back or maybe back of the mind, sepsis is a vasodilatory state. You just bound to give the fluid. Ye de bhaiya 200 ml, but that is not the scenario. You are supposed to see inside what is happening as far as the monitoring is concerned. So the modern mantra, what is the modern mantra of the fluid management is test before you infuse. That is the most important thing. Without that, the management is very, very difficult. So the take home is the evaluation from rigidity protocol to the flexible individualized approach will give the positive outcome. That is the most important thing what should take in from this my talk. Thank you very much for your precious time. I think I've just, thank you very much.
Thank you, sir, for that wonderful deliberation. Now I request all the expert panel to facilitate our orator. Also,
I just want, can I take one
Yes,
minute?
yes.
I would like to thank my organizing team, the scientific committee. They have really bestowed me this oration of Maha Criticon of this Nagpur Maha Criticon. To name Deepak, Sudhir Chafle, Nikhil Balankhe, Rajan Barokar, Jayesh Timane, Sapna Kanzode, and so on. There are almost like 20 people. I am really thankful to you from my soul. Thank you very much.
Also, may I invite Dr. Jayesh Timane, sir, to read the plaque prepared in the honor of our orator. A big round of applause for our beloved Nirmal sir.
The plaque presented to Dr. Nirmal Jaiswal, sir, it reads, 13th Annual Conference of Maharashtra State Society of Critical Care Medicine, Maha Criticon 2025 oration by Dr. Nirmal Jaiswal. We present to you this token of respect and awe as heartfelt appreciation of your invaluable contribution to the field of critical care medicine and for delivering the oration on hemodynamic monitoring where are we at Maha Criticon 2025 Nagpur on 8th November 2025. You have been instrumental in establishing faith in critical care medicine as an independent and important branch in the city of the Nagpur. Your unwavering dedication, tireless hard work, steadfast vision has been remarkable. Your profound insight, scholarly excellence, and compassionate leadership has paved the way for many and continues to inspire us all. With deep respect and admiration, we honor your achievements, your integrity, and your continued pursuit of excellence. Signed, Dr. Deepak Jeswani, the organizing chairman, Dr. Sudhir Chafle, organizing secretary, and Dr. Ashish Ganzre, chairman, SCCM Nagpur.
She did not require dialysis, she did not require ventilations. So that is the beauty of this obstetric cases. As we have seen that these patients, if there is timely management, resuscitation is done. For that matter, you do not have to pinpoint a diagnosis. Actually, survival rate is very good. And if it is beyond second trimester, nowadays the fetal survival is also good. So early referral, take consultations from the nearest referral hospital by tele-ICU facilities. These are the two things I think which in the digital era can help saving these patients. So this is the second and the last case. 28-year-old lady, 30 weeks pregnancy at village. ANC check was irregular. Now 2 weeks before she was diagnosed of high blood pressure and started on some medicine. Most likely preeclampsia was there. The one day she had pain abdomen, water leak, she was taken to a local district hospital and CS was performed for fetal distress. Baby could not survive. Now post-op after 8 hours, she was found to have jaundice, bleeding with PPH and she was given some pack in situ and while she sipped with oxygen. She became drowsy, hypotensive and shocked and deeply jaundiced with low urine output. Now these are the lab findings. You can see severely deranged liver functions, creatinine is high and deranged coagulation. So what are the differential diagnoses? These are the almost 5 I have written. What is more likely in this case? Post-op, severe deranged liver functions with all multi-organ dysfunctions, counts are high, low platelets, and she is already just diagnosed to have preeclampsia in the before delivery. Anything is possible, right? She was intubated, ventilated, we dialyzed, we gave all this blood products along with some factor concentrator also, but there was rapid production of organ failure and she succumbed. Most likely the acute liver failure of pregnancy, it has got a disproportionate rise of liver functions compared to all 5 etiologies which I have put as a diagnosis. These are the patients who actually, if anything, it is unique to pregnancy, usually it improves after delivery of the fetus. But AFLP is a diagnosis actually as the etiology, which tends to, once it has come to a stage of decompensation, they tend to rapidly decompensate and usually mortality is very high to the tune of 80%. In the last 2 weeks, actually, we had two obstetric sessions in the critical care conference in Chhattisgarh, one in Raipur and in Bilaspur, and we were interacting with our ONG obstetrician friends. For some strange reason, there has been more presentation of these AFLP cases now in the community. They just walk in with bad liver functions. By the time you decide stabilize and planning delivery, this patient just fulminantly go into hepatic failure and dying off. So this is something that I just wanted to share with from my experience. And HELP syndrome we have already discussed. One of the criteria is mostly it is associated with severe preeclampsia. If you do a blood smear, there will be microangiopathic hemolysis with the blood cells. This we have already discussed, and just draw your attention to this homozygous deficiency of this particular enzyme, which is actually responsible for causing this AFLP manifestations. If there is a heterozygous gene, so gene screening may not be actually just heterozygous gene is not risky. But if you have a homozygous presence of this gene, then this is the one which is high risk. And challenges are there in terms of all these patients who have got multi-organ dysfunctions, challenges in there in administration of anesthesia for delivery purposes, because you need to have at least, if you are planning a neuraxial block, the platelet count need to be at least more than 80,000, for cesarean section more than 50,000, and high risk content must be obtained for all these cases, because the only chance we have to save the mother is to do the delivery of the baby without documentations, because otherwise there are chances of medical legal issues are very high in such cases. So management, as you manage any other sick patients, ABC of resuscitations, termination of pregnancy, with encompassing this anesthetic challenges, multidisciplinary team approach from the very beginning and counseling by the obstetricians, by the pediatricians and anesthetists with the involvement, close involvement of the critical care team is paramount importance. You cannot manage these patients, stabilize and just shift to a nearest referral center. And what about liver transplant in patients who face or land up in acute liver failure? Literature, if you see, very, very scarce data, because this King's College criteria, all those scores, etc., which have been done, they have not been validated in pregnant populations. They have been developed long back, and none of them, you know, see, all major studies for that matter actually exclude pregnant patients. So whatever the established therapy we talk about in non-pregnant populations cannot be applied to this pregnant population. Having said that, only is the paracetamol-induced acute liver failure, which is probably not an obstetric cause per se. They are the ones who can be extrapolated and be applied this King's College criteria for liver transplant. AFLP cases, when you have the facility or the infrastructures, they also can be considered for liver transplants. One of the series which actually almost looked at 1900 liver transplants, only 0.5% of the cases had pregnant ladies had liver transplant. But again, the graft survival or the functioning at the end of 1 year, 2 year success is not so good. HELP, 0.5% of all the HELP cases which are mentioned, I mean data is available, have probably been considered for liver transplant. Again, success rate is not so good for such cases. Prepare for delivery, I think more or less we have discussed about it. Along with the mother, also think about the baby. If it is 24 weeks of pregnancy, plan for the lung maturity, have a neonatologist involved, and all other general organ support therapy should be provided. What about extracorporeal therapy? I think we had one of the sessions just before in the afternoon. Heme absorption therapy, as you normally contemplate for any other forms of acute liver failure, can be considered. That is, this Mars Plex can be considered. It's not difficult because you can use the same CRT machine with a specific unique filter which is there, and it is said to absorb the inflammatory cytokines or this liver related toxins would be absorbed. But again, evidence is not high in its support, because again, pregnant populations are scarcely in literature. Some of the unique etiologies not to forget, because most of the literature that we study are from the Western countries. We have sickle cell, we have tropical fevers. This just need to be managed conservatively in the timely manner and to be referred to a higher center for better management. Most of them do very well with 90% of the survivals and good outcomes. So summarizing, I would say history and clinical examinations are the way forward. First, whenever you receive a patient, these are the things which will clinch you 90% of the diagnosis. Stick to basis in cases of resuscitations, because I strongly believe, be it life or clinical science, common things are common and uncommon things are uncommon. By doing small little things at the right time, actually, you can save more lives than not. Termination of pregnancy as appropriate with a quick assessment is important, is going to do the wonders. Mixed and overlap diagnosis would be there. At that point of emergency, you did not pinpoint A, B, C, D, what is the diagnosis. Just manage the patients and at the same time parallelly keep on working on the investigating. Early referral to the nearest center and taking help of tele-ICU in today's era's time I think is going to be extremely helpful. With that, I conclude my talk, and I am happy to invite you for this obstetric critical care workshop, which is going to be held in the Criticon 2026 at Chennai. And this is the ICC manual of obstetric critical care, and there is also a 6 months obstetric care fellowship course which National ICC am running, and twice a year there is enrollment for that same. Thank you very much for your patient listening. Any comments or questions, welcome.
Thank you, madam, for sharing your valuable clinical insights. We now open floor for brief discussion, question and answers.
Thank you.
My question is regarding pulmonary embolism. I think this question can be taken by both Kapil or Dubey sir. The thing is, in the immediate postpartum period, if there is a scenario where there is a massive pulmonary embolism, as there was a case in sir's presentation, and given that all the modalities are possible, no financial restraint or something like that. So what would be your modality? Systemic thrombolysis or catheter-guided thrombolysis, or probably percutaneous embolectomy?
Given a scenario, we will prefer to go ahead with catheter-directed thrombectomy, because if you look at the possibility of bleeding tendencies, it will be at the lowest risk. And catheter-directed thrombolysis, even though dose is less, we are doing at our center thrombectomies, and we have a good results doing that. So we will prefer doing, but for that we require specialized center, and the team and interventional radiologist has to be there.
I think, in fact, he has organized the meeting, Kapil has organized a meeting, and I was there. So catheter-directed thrombolysis, where you just use the TPA, and the dose is going to be just 14 to 15 milligrams, and the risk of bleeding is less than 1 to 2%. So that becomes a very good option. And second option is definitely going to be catheter-directed thrombectomies. Now, only issue is going to be require an expertise. You require those gadgets and the cost. Cost is definitely, it goes in 8 to 12 lakhs rupees, so that's not a simple cost.
At my center, it will be around 1.5.
Yeah, but that is just putting a catheter and thrombolizing with the TPA. So that's a cheaper one.
Actually, I think penumbra device, whatever is being used for that embolectomy, is available even in maybe district places, in many of the places.
Yes.
Even in our place like Kolhapur, we do have it.
Yeah.
Probably we should take more benefit of that in such scenarios.
Thank you all participants for those thought-provoking questions. And I would ask, so now I request Dr. Ashish Gandhi to felicitate our speakers and chairperson. Thank you. So we conclude this session. It's clear that obstetric critical care continues to evolve as a crucial subspecialty and which demand multiple collaboration with multiple teams.
Thank you everyone for the successful completion of day one of the conference. Just a general announcement. Tonight we have our gala dinner for all the faculty and delegates in the same hall. We have Central India's one of the biggest band. Please request everyone to be present and enjoy the evening 8 p.m. onwards in the same hall. Tomorrow morning we'll start again sharp at 9 a.m. So request everyone to please be present in the same hall at 9 a.m. tomorrow morning. Thank you.